Morning, everyone, and welcome to the House Committee on Health and Human Services and Elderly Affairs. As noticed in the calendar, we have several bills that we'll be meeting on today in executive session and discussing. But before that, I'd like you to please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. We have 5 bills noticed for today. One of them, Senate Bill 240, there's a subcommittee working on that bill, and the subcommittee has not finished its work yet. So we will be continuing Senate Bill 240 until next week, but we will be discussing the other 4 today. So I'd like to start off with Senate Bill 127, and I understand there's an amendment. Representative Shapiro, did you want to speak to that and introduce that? Sure.
First, okay, I would, this is actually Representative Weber's amendment, but she wasn't able to be here today, so I'm going to introduce it. I move to adopt Amendment 1457H to Senate Bill 127.
Okay, is there a second?
Second.
Representative Leon seconds. Representative Shapiro, would you like to speak to your motion?
I think that Representative Weber spoke to this last week. Essentially, this is a response to Representative Edwards' query about how confusing it was about what the initial fee shall be for providers of methadone detoxification and maintenance programs. And this clarifies the language and puts into effect what the actual policy as practiced currently at DHHS is. So that is, the initial fee shall be $1,000, and that's kind of a startup fee. And annually thereafter, the fee shall be $8 per client based on the client annual census of the previous calendar year. So I don't think we're making any change from what's currently in statute or currently is practiced. But it just clarifies the language.
Okay, thank you. Other discussion on the amendment? Seeing no other discussion, so I'd ask that the clerk call the roll. The motion is ought to pass on Amendment 1457H to Senate Bill 127. And two other members are coming back just in time. Gentlemen, you have impeccable senses of timing.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Copal,
Yes.
Representative Boyd,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Cannon.
Yes.
Representative Wallner,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
Yes.
Representative Lloyd,
Yes.
and Representative McDonald.
Yes.
20-0.
Okay, great. Okay, I know of no other amendments to this bill. Is there a motion of ought to pass as amended? If not, I can make that motion. I'll move ought to pass as amended. Is there a second? Representative Cannon seconds. Any discussion? In terms of speaking to my motion, I think the department made a compelling argument. I appreciate Attorney Williams and his array of, his entourage that he brought that morning to testify on the bill. They gave us, in my view, a very comprehensive account of what the bill did, what it needed to do, and many updates in terms of statutes and other things, and that for that reason I'm inclined to support it. Any other discussion? Representative Leon.
Thank you, Mr. Chairman. And I'd like to thank both the sponsor and the department for bringing all these important factors together. I do want to express my disappointment that this did not come across as 6 separate bills. Sections 1, 2, and 16 could have been one bill that would have been all on one topic on substance use disorder. Sections 3 and 4 should have been one bill on personal care services. Sections 5, 6, and 7 should have been one on residential care, assisted living, and nursing facilities. Sections 8 and 9 deal with beverages, entirely different than the rest. That could have been one bill, so we could have better understood what was happening. I'll be generous and put section 10, 11, and 12 together because it has the MEAD program and SNAP, and they're all social services, and it's just some basic revisions. So that would be the 1, 2, 3, 4, 5th small bill, and then there was a small cleanup one on reports. I couldn't see any of those hearings taking very long, and those are the sort of things where we could look at it and say, look, this makes a lot of sense. Any objections to moving forward with an executive session right now? I greatly appreciate that this is not the Tale of Two Cities that we had last year, but still, I want to see these bills come through independently. And because of that, I will be voting against this, not because of the content of the individual sections, but because I believe the best way to legislate is to allow each of these topics time and mind space to think about each section separately.
Other discussion? Seeing none, I will ask that the clerk call the roll. The motion is ought to pass as amended on Senate Bill 127.
Representative Leon,
No.
Representative Cushman,
No.
Representative Bill King, yes. Representative Kofalt,
No.
Representative Boyd,
No.
Representative Seth King,
Yes.
Representative Mazur,
No.
Representative Nagel. Representative Pelosi,
Yes.
Representative Cannon,
Yes.
Representative Wallner,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham. Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
Yes.
Representative Lloyd,
Yes.
and Representative McDonald.
Yes.
15-5.
15-5, and that'll go on the regular calendar. Is there going to be a minority report on that?
I can write a minority report on that.
Okay. I'll write the majority report. Okay. Very good. Okay, moving on. Next up is Senate Bill 200. And I believe there are a couple of amendments for that. Representative Polozov.
Mr. Chair, I would like to move Amendment 2023-1583H.
Okay, is there a second? Representative Mazur seconds. Representative Polozov, would you like to speak to your motion?
Yes, thank you, Mr. Chair. I would like to speak in support of Amendment 23-1583H. This amendment is a cleaner version of amendments that I offered in the previous executive session, and I'm thankful to committee members for their feedback on my previous amendment. Specifically, I'm making sure that flu vaccines stay in place because I got a feedback from you that flu vaccine is an important part of a very popular vaccine. And also another improvement is that this amendment does not introduce vaccines that were not called for by underlying bill, and that we found out primarily popular in administration for kids, and this bill is not dealing with that. At the same time, this amendment make sure that we are putting some pause in expanding of administration of COVID-19 vaccines because science is quickly evolving on that. Initially, we thought that those vaccines are safe and effective, and it took 2 years to recognize the connection between COVID-19 vaccines and myocarditis. Unfortunately, myocarditis is a red herring. Myocarditis is only 1% of severe side effects that those vaccines are causing. Now, last month, there was a recognition of connection between COVID-19 vaccines and stroke, which previously was denied. And there are more signals that are coming along. Those graphs that I passed to committee members, you can see that in New Hampshire there are more, for example, miners who died following COVID-19 vaccines administration than following COVID itself. But also, if we look into some New England populations that are heavily vaccinated, there are at least a dozen of different death codes that are through the roof, mostly related to circulation and blood. And while COVID itself is a serious disease that seasonal and might cause things like pneumonia, death, respiratory system is being damaged. At the same time, we see that COVID vaccines, for some reasons, are causing things with circulation. For example, you can see a graph with lymph node cancer that was steady more or less before, and it didn't peak in 2020 when there was peak of people dying from first wave of COVID. But after introducing of vaccines, more than 200% increase in deaths from this kind of cancer. And many of you heard about people experience painful symptoms after these vaccines in their armpits where lymph nodes are located. And usually it's considered to be not a big deal and it's going away. But as you can see, in some cases, it doesn't. And it might take months or even years for it to take effect. And in first quarter of 2023, it's increased again more than almost like 400% comparing to what it was before the introduction of this vaccine. That's why this amendment is asked for a reasonable pause of 2 years with these specific technologies, so we could investigate it and take reasonable precautions. And that's the amendment. Thank you.
Thank you. Other discussion, Representative Murphy.
Thank you, Mr. Chairman. I will vote against this amendment for many reasons. I appreciate the concerns that Representative Polozov had mentioned, but I would say that that's his opinion and not fact that has been borne out in the literature. You have to remember that the request from the optometrist was specifically in response to COVID and the pandemic. And during my lifetime, and many of us here, we have lived through at least 8 different epidemics or pandemics, and we are certainly going to see one again. And therefore, I think having others available to give, vaccines, shots in arms, and the access for the patients, whether it's in the pharmacy, at your primary care office, or in the optometrist office, I think is important. You have to also remember that this messenger RNA technology is not new. Messenger RNA was first discovered in the early 60s, and it's been, tested and retested and implemented and used, and probably since the early 90s. The nanoparticle technology was approved in 1995. And so this is the first true application of the messenger RNA technology, along with the nanoparticle, that was used to introduce the antigen into the cells so that the T cells can respond in an immunological response to the spike proteins on the COVID particle. So I think it's wrong to think about this as new technology. Messenger RNA has been around a long time. The work on messenger RNA in this manner has been going on for several decades. To me, to discount the COVID vaccine for a group of people in response to another pandemic may come along, and that will probably have a vaccine that uses this technology, is like saying I want to stay with my rotary phone versus going with a 10 series for my iPhone. So I don't understand discounting the technology for this purpose alone. It has been around a long time. I think it's been proven to be very effective. And you have to also remember that the FDA gave its full approval to this over a year ago. And the FDA does continue to monitor all the signs and symptoms that people have. And in fact, when the Johnson & Johnson vaccine came out, that was actually, its authorization was pulled by the FDA. So they do look at the data, they respond to it, and they act accordingly. You also have to remember that over 500 million COVID vaccine shots have been given worldwide, and the incidence of adverse reactions is de minimis. So for those reasons alone, I will have to vote against this amendment. Thank you.
Thank you. Other discussion? Representative Merchant.
Thank you, Mr. Chair. I also will be voting against the amendment. I do hear the concern by the representative, although I don't always share the concern. I'm looking at it somewhat different than Representative Murphy. I'm a strong believer in standard of care should be universal. We should have one standard of care regardless who the provider is the patient goes to. So in saying that, if we're going to allow all the other providers to give COVID vaccine and single out optometrists, I don't think it's really creating a standard of care across the state of New Hampshire, which should be my goal. And number two is that this is voluntary. It's not mandatory. So therefore, it's up to the patient. I think I really believe in patients' freedom of choice. And the patient should have the freedom to choose, if they want to get the vaccine or not. And quite frankly, where they want to get it, whether it's an optometrist, a pharmacy, or a physician's office, nurse practitioner. So for those reasons, I will be voting against the amendment.
Thank you. Other discussion? Representative Polazov.
I'd like to react and thank you, Representative Murphy, to pointing out this that this is a specific request in relation to COVID pandemic. So let's imagine a best case scenario that something like this bill would be in place and optometrists would be using their workforce and their good reputation to overcome vaccine hesitancy in New Hampshire and deliver these shots into the veins of as many New Hampshire residents as it would be in other New England communities. So how many infections would be stopped and how many lives would be saved? And my point is, it doesn't stop an infection, so infection wouldn't be stopped. And from the data that we are seeing, I would argue that a couple of hundred more New Hampshire people would die from side effect. And we are hearing side effects are minimal. We are hearing it's just a few per million. But every member of this committee knows that side effects are underreported. And also, in one of the political caucuses in this committee, a little bit over a dozen people well vaccinated. 2 people publicly came out as having severe side effects from this vaccine. So it's for me, it's not a few per million; it's a few per dozen. So side effects and deaths from side effects are severely underreported, and that's why I urge you caution. And another argument we heard last week that there was some underreporting, some concealment of information from people, but it's a free choice. I mean, it's a free choice if we all go to our constituents and we will tell them that side effects are severely underreported, and that we know that like several members or substitutes in this committees had severe side effects of it. But it's not happening. When optometrists will be injecting these vaccines to people, they wouldn't be sharing the information that this committee knows. So that's why I don't see it as just a free market approach, because information is hidden from people. Thank you.
Thank you. Representative Bill King, did you still want to speak? No? Okay. Any other discussion? Okay, seeing none, I'll ask that the clerk call the roll. Motion is to pass on Amendment 1583H.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
No.
Representative Boyd,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Representative Pelosi,
Yes.
Representative Cannon,
No.
Representative Wallner,
No.
Representative McKay,
No.
Representative Freitas,
No.
and Representative Nutter Upham,
No.
Representative Shapiro. No. Representative Merchant,
No.
Representative Murphy,
No.
Representative Palmer,
No.
Representative Lloyd,
No.
and Representative McDonald.
No.
8 to 12.
Okay, and that will go on the regular calendar.
No,
What's that?
You want to?
that was the amendment.
Sure. Is it going to be a minority? Wait, are you doing a minority on that? Oh, that's right. I'm sorry. I'm sorry. Okay. So the amendment fails. Representative Merchant, I believe you have another amendment.
I do, Mr. Chair. It's the same one I think I sent out to everybody electronically, but just in case people don't have it, I've made copies as well. So you can send it this way, send it this way. Yeah, and I'll put some out in the audience wants to see it. Yeah, nothing to go around, but.
Thank you. If they need more.
Yep.
Okay, Representative Merchant?
Thank you. So as I said earlier on the other amendment that was proposed.
Actually, do we have a motion?
Oh, motion, sure, thank you. I'll make a motion to pass House Bill 2023 1568H
Is there a second?
amendment.
Representative Shapiro seconds. Would you like to speak to your motion, Representative Merchant?
Thank you, Mr. Chair. So, as I mentioned before, I'm a strong believer in having a standard of care across all disciplines, dealing with consistency for the patient's sake. And I worked with Representative Cushman on this as well. She brought it up during the hearing that the requirements for an optometrist to give the vaccine is somewhat different than the requirements for the pharmacist to give the vaccine. So what we did collectively was go back and look at the RSA for the pharmacist and basically at that point in time take the same requirements that they are required to have and insert those requirements into this statute. And the requirements are they hold a current license to practice, which is understandable. They complete the training course. They have $1 million in liability insurance, a waiver for this specifically. They hold an active certification in basic cardiopulmonary resuscitation, and they provide to the Board of Optometry the documentation. They have all of this in place before they actually can immunize. So I think it's a logical thing to do is that you want to protect the patient because you want training. If something does go wrong, heaven forbid it does, you want to be sure that there's liability insurance to cover the event if it does. And you also want to be sure that they're providing some sort of a oversight board, in this case the Board of Optometry, that they have in fact met all those requirements before they can actually get the immunization. So that's reasons why I'm bringing this forth to the committee. So that's my comments.
Thank you. Other discussion? Any other discussion? Representative Nagel?
I'm not that familiar with optometry, but $1 million is a lot of liability insurance. Why was that number picked? I'm just curious.
Why?
Yeah.
Because at the time in which the RSA was going through the legislative body, that's what was agreed to.
I figured. Thanks.
So to set the standard.
Representative Murphy, did you have your hand up?
Yeah, thank you. Just a question to Representative Merchant, and I did put this in an email to him. I just wanted to get the answer. Is that you mentioned using diphenhydramine as well as epinephrine and equivalent medications. Given that the patients that have any anaphylaxis reaction also have pulmonary issues, and are treated sometimes with oxygen or an inhale like albuterol, would it be better in your mind to have something more broad in its terminology, like medical management and pulmonary support as per CPR protocols?
It's a good question, Representative Murphy. I wrestled with that because in one sense, yes, it would, but in the other sense, no, because when you get to that level of care, I think the training you need is going to be beyond what they're going to receive in the training of giving the shot. To give an epinephrine injection is one thing. To start giving a patient albuterol, oxygen, and so forth, it's probably time to call the EMT.
Follow up?
I would agree, and I appreciate the response. I was just thinking before the EMTs get there, would they be better off served to have oxygen available and any other medications as per CPR protocol? That's all. Thank you.
Thank you.
Other discussion? Seeing none? Okay, the motion is out to pass on Amendment 1568H.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative Boyd, Yes. Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Representative Pelosi,
Yes.
Representative Cannon,
Yes.
Representative Wallner,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
Yes.
Representative Lloyd,
Yes.
Representative McDonald.
Yes.
Amendment passes 20-0.
Thank you. I know of no other amendments. Do I have a motion about to pass as amended?
Make a motion out to pass as amended.
Okay, is there a second? Representative Palmer seconds. Any discussion on the motion? Seeing Representative Leon.
Thank you, Mr. Chairman. I do want to thank Representative Murphy for his point about the potential dangers that can happen once you start having these different issues. I know that there's the medical freedom side of the argument here, saying that as long as you have the adequate training, it makes sense to be able to provide these vaccines. There's the question too about how that impacts the competitiveness of different practices. So I see that there can be multiple viewpoints on this about how much of a net positive it is. I know that I'll be supporting this, but I'm not sure, that's one of these where it needs to be left up to our individual conscience to see if we think that the benefits outweigh the risks.
Representative Polazov.
Thank you, Mr. Chair. I'm very thankful for amendment that is passed, but I still will be voting against this bill. I think that optometrists need to be focused on the care of their patients' eyes instead of doing vaccines. And vaccines will be a distraction for the main function. Optometrists typically do not listen to patients' heart. They typically do not take patients' blood pressure, and they typically do not have a handle of the patient's full medical history. Optometrists will be opening themselves to liability with this new responsibility that they will have, and I believe that there's no issues like we don't see like a line of people asking optometrists and seeking for vaccines. So for these reasons, I think it's not needed, and it's opening ask for dangerous situations, especially that it touches such, I believe, harmful medications as COVID-19 vaccines.
Thank you. Other discussion? Representative Bill King.
Thank you, Mr. Chair. And I also will not be supporting this bill overall, even though the amendment was a good attempt. Unfortunately, there's more of looking out for the small optometrists. They have big concerns about this, and so I'm just looking out for the little guys. That's.
Thank you. Other discussion? Seeing no other discussion? I'll ask that the clerk call the roll. The motion is out to pass as amended on SB 200.
Representative Leon,
Yes.
Representative Cushman,
No.
Representative Bill King, no. Representative Kofalt,
Yes.
Representative Boyd,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
No.
Representative Nagel. No. Representative Pelosi,
No.
Representative Cannon,
Yes.
Representative Wallner,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham, Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
No.
Representative Lloyd,
Yes.
and Representative McDonald.
Yes.
14-6, it passes.
Okay, we'll go on the regular calendar. I'm assuming there'll be a minority report on this. You're Representative Palazzo, do you want to do the minority report on this, or who's doing the majority report? Yes.
Can I do minority report or to pass with amendment that failed, or like what
Yeah,
committee
yes.
feels like?
Okay,
Mr. Chair, I'll write the majority report.
thank you. Representative Leon.
Thank you, Mr. Chairman. I might recommend that if you support, since you supported the committee amendment as well, to have a separate amendment drafted that includes both the committee and that. I'm not sure what the right procedure would be, but I just want to make sure we don't accidentally get rid of those important changes. So we'll get guidance to figure out the right amendment.
Okay, any other comments before we move on? Okay, thank you. Next up is Senate Bill 239. And do I have a motion on that? Actually, there's several amendments, so. I'm not sure who wants to go first. Yeah, I mean, most of it, you have most of them, Representative Nagel, so. Oh, well, you did have 4. What happened to the 4th one?
Microphone.
Microphone?
All right, I should know this by now, but I'm going to do it wrong. I want to move amendment 2023-1581H on Senate Bill 239 for consideration. Did I say that
Okay.
right?
Is there a second? Representative Leon seconds. Would you like to speak to your motion, Representative
Sure.
Nagel?
One of the local TV stations yesterday unwittingly made my case for this motion yesterday. My concern about this bill has been the rights of people in pain and that they not become stigmatized and harmed by this kind of bill. The terminology that was being asked to change, I thought put them at risk. And yesterday on the television station, when they were talking about the opioid crisis, they just showed spilled bottles of pills as their example, and that bothered me a lot. So I thought that this became even more important because that stigmatized our patients. What we did it's on page 1, under 12J-1, it adds the following language, that nothing in RSA 12J should be construed to limit care of chronic pain and hospice and palliative care patients, including the term misuse, which shall be utilized as intended to broaden the scope of work across the substance use continuum of care. My purpose in this amendment was to basically preserve their rights.
Any discussion? Representative Leon.
Thank you, Mr. Chairman, and thank you, Representative Nagel, for bringing this very important amendment. I think that it's absolutely crucial that when somebody is fighting for their life, we provide them the appropriate tools for pain management and worry about addiction after we save their life first. And also, when you're in that much pain, addiction's a lot less of an option, a lot less likely than when you are in a different scenario. So this has my full support and my thanks.
Other discussion? Representative Nutter-Upham.
I worked for 3 years at a hospice house, and I remember seeing patients coming in tremendous pain because their primary care doctor or cancer doctors were afraid to give them like enough medication. And once you're in hospice, I think, you know, a good hospice, they palliate their pain. And I would see these same patients who had come in on a gurney, like awful. 3 days later, they're playing cards in the living room. So, I mean, it's so important that the fear of addiction is inappropriate in a hospice setting, and that it's so wonderful when people's pain can be palliated. It's humane. So thank you.
Representative Leon.
Thank you, Mr. Chairman. I think that I will actually expand a little bit on this. The palliative care also isn't necessarily end of life. If I can talk to a personal reason why I'm supporting this, my mother-in-law developed a bed sore, and she had one that was grapefruit sized. And when she was sent to a hospital for wound care and pain treatment, she was given Tramadol. Pretty much all of her last words were 10, 10, 10. For pain, because they refused to get a consult in order to actually appropriately manage her pain. And by not managing that pain, her body was so busy dealing with that pain, it was unable to fight off the infection and the assault on her bodily integrity. Had she had pain management, she still might not have survived, but she would have had a fighting chance. When she got transferred to another hospital that actually took pain as a vital sign and took pain as an important thing, she relaxed and she finally knew that she was getting help. If this amendment, if this it has one small part to keep other people from going through that torture while trying to fight for their lives, then we've done good things this year.
Representative Nagel.
Thank you. That was wonderful. I also want to expand this discussion just to say that for the record, and again, I was very concerned and upset about the public portrayal of the patients I represent on a local television station yesterday, but roughly 66 million people in the United States suffer from chronic pain. 20 million have what we call high impact chronic pain. We estimate 15 million of those people who do not benefit from other therapies can benefit from long-term opioid therapy, and the public policy response to the opioid crisis, which addresses fewer than 2 million people with opioid use disorders, 60% of whom had a prior substance use disorder that predated their opioid use disorder, is basically served to harm them, creating a public policy or public health crisis that we refer to as opioid refugees who are not getting care that they need, getting denied access to treatment that had worked, and resulting in unnecessary suicide, unnecessary going to the street to treat their own medication, or suffering needlessly. And I think that their needs need to be recognized too, and that was the other reason that this was important.
Other discussion? Representative Merchant.
It's more a comment. I wanted to thank Representative Nagel. One of the things that caught my attention was the fact on line 4 and 5 is the word other drug, which basically implies alcohol itself is a drug. So I wanted to say thank you for that and recognizing that we have alcohol as a drug and not looking at it as a non-drug.
Other discussion? I'm seeing no other discussion. I'll ask that the clerk call the roll. Motion is ought to pass on Amendment 1581H.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative Boyd,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Yes. Representative Pelosi,
Yes.
Representative Cannon,
Yes.
Representative Wallner,
Yes.
Representative McKay,
Yes.
Representative Freitas,
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro,
Yes.
Representative Merchant,
Yes.
Representative Murphy,
Yes.
Representative Palmer,
Yes.
Representative Lloyd,
Yes.
Representative McDonald,
Yes.
20-0 passes.
20-0. Okay, and I believe you have another amendment, Representative Nagel.
These were handed out. Oh, yeah, 2023-1505. I handed them out. A Boy Scout, and I'm prepared.
Thank you.
No tree farm. I would like to move that amendment 2023-1505H to SB 239B ought to
Okay.
pass.
Thank you. Is there an second? Is Representative Missouri seconds? Would you like to speak to your motion?
Sure. If one turns to page 5 on the bill, at the bottom on line 25 under continuing medical education, Senator Waters and I actually worked on this together. He had listed a recommendation for doctors for CME for basically substance use. I had pointed out to him that that actually already existed in medical rules. So all we did was we struck his language and we put the existing language from the Board of Medicine's rules, which basically says all licensees are required to register with the controlled drug prescription health and safety program shall complete 3 credit hours of approved online continuing education or pass an online examination in the area of pain management or addiction disorders. That is actually more stringent requirement than what he had written, and we think it's important. I should add one more thing. The average doctor gets, in his training or her training, 7 hours of training in pain management. The average veterinarian actually gets substantially more than that. The average doctor gets very little, if any, training in addiction medicine. So I don't know about veterinarians on addiction, but anyways, we do believe that that's a huge hole in medical education, and this is a way to fill that hole, and that's why that language was inserted in the state rules.
Sure. Representative Shapiro and then Representative Merchant.
Thank you, Mr. Chair. Thank you for bringing this amendment, and I'm just curious why it doesn't say "and addiction disorders" as opposed to "or addiction disorders."
The way it's listed right now is a doctor can use that 3 hours for either. So in other words, like it has to be done every 2-year cycle. So one cycle I can do one. The reality is pretty much every exercise we do includes both within it, but you can do either or.
Representative Merchant and then Representative Murphy.
Thank you, Mr. Chair, and also thank you, Representative Nagel, for bringing this forth. It's more of a procedural issue. The way this is written, and I'd like someone else who's more involved with the process here. This is in the RSA governing physicians and surgeons. So when you say all licensees, I think I know what's implied. However, because it's in the RSA chapter for physicians and surgeons, it's only for those who are licensed by the Board of Medicine. It would not include people from the Board of Dentistry, people from the Board of Naturopaths, people from the boards, other boards. So I just want to bring that to people's attention. If someone could clarify that to me, it'd be helpful.
That is a really important point, and I spent about 2 hours last night at a restaurant scrolling through every rule in New Hampshire to figure this out. So, and I think that's an important thing, and it needs to be included. It turns out that dentists actually have in their rules, they do have pretty much the same language doctors do for their requirement. So it's in rules now. I actually my wife's an NP, so we talked about this last night. There's no place in the NP rules that actually specifies that they need to do this. However, so I asked, I know she has to get 3 hours. So I asked, where does that come from? She said it's from the DEA registration requires that you do that. That I didn't have time to look into, but they're important things that should be added at some point. I'm not totally sure if this is the right place to do that. But I think we have a lot of work with those boards to make sure those things are addressed.
Follow up?
Just for clarity, so you're, through this amendment, looking strictly at physicians and surgeons and PAs. This would not include nurse practitioners, dentists, and so forth.
I'm not sure it includes PAs either, for that matter. It is an important addition, and we certainly could work on that if you want. I think it's an important addition.
Representative Murphy.
Thank you, Mr. Chairman. And maybe this was answered by Representative Nagel, but I'm trying to clarify why we need the language in the first place. As you know, we obviously have to have 3 hours of CME credits. Every 2 years, you have to get your license renewed. You have to have 100 hours of CME credits, 40 of which have to be Category 1, and of that 40, 3 have to be for pain management and addiction. So we already have that in statute. In fact, the statute is RSA 318-B:40. So one of my questions was, why do we need to have that language into this bill right now? And also in response to your comment about, how many hours the vets have to have versus the physicians, the DEA just came out with a new one-time ruling that all physicians have to have a one-time 8-hour course in addiction and pain control. So that was effective as of December of last year. So I guess my question was the need for having this language if it's already written in statute elsewhere.
I'll look through the statute again. I wasn't aware it existed in statute, just in rules. I'd be honest with you, I had really mixed feelings about this being in statute because it is clearly in rules, and it's in rules for all 3 boards right now.
Right.
Yeah, I mean, is it absolutely necessary? That's the way it was brought to us, and I'm not sure I can make a convincing argument for that.
Other discussion. Your Representative Merchant.
Thank you, Mr. Chair. Representative Murphy, the DEA requirement, that's strictly for physicians or anyone who has the ability to write a prescription for an opiate?
I believe it's for anybody that can write for the medication.
Thank you.
And it's 3 hours out of the 40 CME credits, category 1. But like I said, there's a new new rule that came out through the DEA as of December of this past year that requires a one-time 8-hour course in opioid and pain management.
And again, that's for all providers?
Yes,
Thank
I
you.
believe so.
Representative Nagel, did you?
Yeah, that's a really important point. And the other thing we always have to remember too is that criteria that if you're registered with the DEA, you need to do that. If you're not registered with the DEA, like some nurse practitioners are not, the minute you put this in statute, then all of them have to do it, even if they don't provide any addiction or pain services. So that probably doesn't make any sense. So that's why my wife said that that was not unnecessary for NPs.
Other discussion? Any other discussion? Seeing none, I'll ask the clerk call the roll. The motion is ought to pass on Amendment 1505H for Senate Bill 239.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative Boyd,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel. Representative Pelosi,
No.
Representative Cannon,
No.
Representative Wallner,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Nutter Upham, Representative Shapiro,
No.
Representative Merchant,
No.
Representative Murphy,
No,
Representative Palmer,
Yes.
Representative Lloyd,
No.
the tiebreaker, Representative McDonald,
Yes.
11-9, the amendment passes.
Okay. By the way, we need a second, we need to find out who made the second on the First Amendment?
On the first, I
made the
second on that one.
Okay,
Thank you.
I have another amendment as well.
okay. Representative Nagel still has some amendments to go, so.
Fantastic.
You have a, okay.
So just for the record, I had never done an amendment before today, so I'm kind of
Making up for lost time.
Yeah, exactly. So this is, I would like to move, amendment 2023-161H on Senate Bill 239 as,
Sorry, what was that number again?
2023-161H,
Okay, 18H. Okay, thank you.
as ought to pass.
And is there a second?
Second.
Representative Merchant seconds.
Um,
You
yeah.
may speak to your motion.
So when this, again, getting back to what I said with the First Amendment, one of my big concerns with this bill was that there were a lot of terms being used that were not being defined. And so I looked through statutes and found out that none of them were defined in statute either. So we kind of felt, a number of us, that these holes needed to be filled. So there were basically, misuse was used as substitute for the word abuse. And what I found interesting about that word was that it was extremely hard to find a definition of what that actually meant. And I looked at NIDA, I looked at SAMHSA, I looked everywhere. So there's a clear definition for that as it applies to prescription drugs, but not to drugs in general. So if we were going to use that broad change, I thought that that really needed to be defined. The other term of importance was harm reduction. There is a pretty good overview of that in the governor's commission report on alcohol and other drugs. And if anybody wants to, can refer to that. But what we basically did for that, and this is the senator's edition, Senator Waters, on, he took the definition from SAMHSA, which is fairly consistent with what the governor said. And the reason why all these are important, again, is that as the Opioid Abatement Commission and the Governor's Commission start to work better together, which we think is really important, it would be really helpful to have nomenclature that we can use consistently with each other. The other issue is that harm reduction is becoming a bigger and bigger issue. And in Senator Rosenwald's earlier bill that we saw, that was a big part of that bill. So we really need to define what we were talking about. With that as a background, I chose to look at prescription drugs, and this is going to be an addendum at the end of the bill, so it's not replacing any language. There were two things. There was misuse of prescription drugs, and I'm hopefully missed. Yes, yeah, I'm sorry. No, she did include both. So the first thing was I separated drug misuse and misuse of prescription drugs. Misuse of prescription drugs is a well-defined thing. In SAMHSA's NIDA's criteria means taking a medicine in a medication in manner or dose other than prescribed. It's a very broad topic. Abuse is a very minor or small part of that. For example, if I'm prescribed one Percocet every 4 hours and I take it one every 2 hours, then that would be classified as misuse. If I shoot up heroin or that oxycodone, that would be considered abuse. That's why the difference is important. Drug misuse is a separate thing that we worked on together, again, looking at SAMHSA and NIDA background. Drug misuse refers to the use of a substance for a purpose that is not consistent with legal or medical guidelines. The other one was harm reduction, and that's in section 5. And really, basically, this is very similar to the governor's definition. It's harm reduction shall mean an approach that emphasizes engaging directly with people who already use drugs to prevent overdose and infectious disease transmissions, improve the physical, mental, and social well-being of those served, offering low threshold options for accessing substance use disorder and other healthcare services, and promoting a philosophy of hope and healing by utilizing those with lived experience of recovery and the management of harm reduction. Stigmatization was an important issue that's not mentioned right in that, but it's implied in those. The governor's overview, if I can do that, there's 6 points to it. The first one is to enhance capacity of harm reduction programs, ensure the availability of opioid reversal education, naloxone, things like that, and availability, expand access to drug checking services throughout the state, expand the utilization of harm reduction strategies through street outreach, drop-in centers, peer support services, critical time intervention programs, develop and implement the strategies to reduce the stigma, again, regarding harm reduction services. I have a lot of patients that are stigmatized on methadone. That's another long story. Expand engagement of healthcare providers, and this is where the education comes in. Expand engagement of healthcare providers and health systems in providing harm reduction education materials and services. So that's why those things were added.
Other discussion? Yes, Representative Murphy. Excuse me.
Need some water?
No, I got some.
Okay.
Thank you. Thank you.
Thank you very much. My question is, Representative Nagel, I agree with all the wording that is in your amendment. My question is whether it's simply broad enough. And regardless of the governor's commission, definition of not, if we put into statute a harm reduction definition and it's too narrow, does that narrow the scope of potential, modalities of treatment down the road? Would it be better in your mind to simply refer harm reduction to the SAMHSA definition? For those not familiar with SAMHSA, SAMHSA is Substance Abuse and Mental Health Services Administration. That was actually established by the U.S. Department of HHS in 1990 something. But they have in their website a very broad definition, including things like education, condom use, HIV testing, and that sort of thing. And so my question is, would we be better served having a reference to the SAMHSA definition so that it includes all the various, treatment modalities and education that goes along with it.
Yes.
Okay.
No, I agree. I personally think broader is better. That's my opinion.
Representative Merchant.
Thank you, Representative Nagel. Thank you for the amendment. On line 6, you talk about misuse of prescription drugs. However, when we go back and look at the amendment we first passed, it talks about alcohol and other drug misuse. So my concern is that we're sort of have a conflict between the two definitions. And what I'm trying to get to is that you could have misuse of alcohol as well as drugs. So it doesn't always have to be a prescription drug per se. It could be something that's an alcohol with it. So it also means taking a medication versus using a drug. So I'm just concerned that this definition conflicts with the other one we just passed.
So that's a really important point, and I'm not happy seeing how this was written up because it's not the way I presented it. The way it was presented is those are two separate definitions. In other words, I agree totally with everything you just said, that drug use of substances is a separate issue from drug use of prescription drugs, and they're separate definitions, and they were intended to be that way in what this amendment was.
Should we,
Yeah,
Mr. Chair,
go ahead.
Sure, go ahead.
would you be amenable to sending something down to OLS and try to get this changed as quickly as possible? Thank you.
Sorry, this just went to them last night. Just saw it for the first time. Thanks for pointing that out.
Representative Polazov.
So I have a comment and question. Comment that I don't see a problem with previous amendment because if previously we defined as alcohol and other drugs, it means that alcohol is also drugs. So I think there's no conflict here.
The issue is the word prescription. You don't need a prescription for alcohol. That's where the conflict, I think, arises.
And
Go ahead.
so my follow-up question is somewhat opposite of the first question. That my concern would be if this definition is too broad, it can open providers to new liabilities and open us to new expenses. So I wonder what committee members think about if these definitions, which I see quite broad, like harm reduction, it includes several broad topics here. So my question would be, with these definitions that are still pretty broad, do you see it opening us to new liabilities, opening providers to new liabilities, opening state to new expenditures?
I don't personally see a liability issue. I maybe can you ask that question again. I'm gonna make sure I understand it better. I'm
Good.
sorry, I missed a lot of what you
Maybe
said in the beginning. I'm
Representative-
really,
Go ahead, Representative Polazov.
The question, basically, do you see these definitions broadening the issue as compared to not having definitions in the underlying bills?
okay, I got
And
you.
by broadening it, are we opening providers in the state for new expenditures to try to address those broader definitions of the drug misuse or harm reductions?
So yeah, as far as misuse of drugs, those are very well defined things. And the reason I was concerned was that some abuse is basically called self-medication. And we need to be really careful about how we define what we're talking about. So for example, people like to quote 12 million incidences of opioid misuse a year. That is an incredibly deceptive number when one considers 70% of those are actually people self-medicating. Like for example, you know, we hear this every day. A patient gets a prescription for Tylenol with codeine or Vicodin or something for procedure. They leave it in their case. They get severe pain. Their doctor won't see them for 3 months. They're in agony and they say, fine, I'm going to take that because I got it. That's called common sense to me personally. But that's characterized as misuse. So by defining these things better, and we have a clear a definition of abuse that's already in statute. We don't have a definition of misuse, and I thought that it was important that that actually be defined. The reason why you separate prescription drugs from non-prescription drugs is that, and I thought that this was also important, is because misuse of a non-prescription drug is very different. Like, for example, now cannabis is a non-prescription drug, and most people that are using are actually self-medicating, but it's a totally different concept. So I thought it was important to bring those things to light rather than just throw this term misuse that can be used for almost anything. And that was my concern, is they said, well, this is best practice. And I said, well, what does it actually mean? So we tried to figure out what they meant by best practice rather than just leaving some nebulous term out there. As far as harm reduction is concerned, I've done a lot of work with SAMHSA over the last 15 years. They're really smart people. I trust and they've been working on these issues for a very long period of time. If you look at the governor's oversight or governor's program that they've developed, it's pretty much straight from SAMHSA guidelines. So, I mean, that I think that there's a little bit of trust involved in here, but I think I trust them to define what the term means. Anyways, I'll leave it at that.
Yeah, Representative Kofal.
Thank you, Mr. Chairman. So just two comments, one regarding the broadness or narrowness of the definition of harm reduction. My concern with the original bill is that the definition essentially doesn't exist, so it's so broad you could drive a truck through it. For what it's worth, I think that the definition of harm reduction offered here is still too broad. So we're going to have different opinions on that. Sometimes if some are against it and some are for it, then you probably hit the mark. The other comment I'll make has to do with references to external organizations. I'm opposed to them. We do this a lot in statute and in rules, that we are referencing what some other body says, determines, puts out as a statement, and those things can change. So when those things change, our laws change without the people's representatives having a single thing to say about it. So without speaking to, whether or not we should trust SAMHSA, they sound like a good organization. I would vigorously oppose anything that included an external reference and sort of left to someone else to create that definition and potentially change it down the road.
Did you want to respond,
Yeah,
Representative?
I really
Nagel, or-
appreciate
and then
that.
Representative Shapiro.
I totally appreciate that. And that's why I didn't just accept the SAMHSA definition, because that's what was provided to me. I tried to look through, again, this is an issue of best practices in the field. So what I tried to do was look through as many sites of organizations and other states, what people are saying, to try to come up with a definition. And I think your earliest comment made the most sense, is that it's a pretty nebulous concept to define. So I appreciate that.
Representative Shapiro.
I just got a message that the Department of Health and Human Services would like to chime in on this issue, that they have some concerns.
Okay. Who's, please come
Jenna
forward.
Higgins.
Sure, thank you. I just wanted to see if I could provide any clarity in this, these definitions at all. So one of the pieces, this is kind of a situation where the language is catching up to the best practice in the field. So as Representative Nagel had talked about, the definition of misuse really is around prescription misuse. And so as you dig into what does that misuse mean, it is broader and really speaks to alcohol and tobacco and other drugs, right? And so we're trying to get to a place where it's comprehensive, where we can both research and fund the full continuum of care, including prevention, right, and get upstream from these issues. And so that's the purpose and intent of the language change, as well as the piece I spoke about in my testimony in our hearing, of the word abuse having some negative connotation and continuing to perpetuate stigma. So that's the purpose of using misuse. The definition in the second line of the amendment that says drug misuse refers to the use of a substance for a purpose that's not consistent with legal or medical guidelines, I believe covers the misuse of prescription drugs, because that would be outside of medical guidelines. So then that may keep it broad enough to not have that first sentence, which I think is covered by the second. The other thing that you could do is that substance use broadly is well defined already, and refers to the use of selected substances, including alcohol, tobacco products, drugs, inhalants, and other substances that could be consumed with possible dependence or detrimental effects. That's the substance use definition, and you could go that direction and use a well-defined sort of definition that keeps it broad, moves away from the stigmatizing language, so it still has the same intent.
Representative Kofalt and then Representative Merchant.
Thank you, Mr. Chairman. So one other comment I wanted to make was with respect to Representative Murphy's statement about concerns that a too narrow definition of harm reduction would close off the path to certain treatment. And one of the things that came up in the hearing, because I asked specifically about methadone, in my research, I had seen methadone classified by some medical experts as harm reduction. And so I asked about it, and the answer we heard from the witness was, no, I would classify that as treatment. So I guess that's another thing that concerns me here is, do we have clarity on what is harm reduction versus what is treatment? Because I don't see any definition of harm reduction would shut off avenues to treatment, but it sort of brings more light to the concern that the definitions are poor all around. And that is my general concern with the bill.
Okay. Representative Nagel.
Can I get your opinion on the harm reduction definition?
Yes, so I think that harm reduction is just any kind of public health intervention that would reduce harm. That's why it feels like that is so broad. But treatment is clearly defined, and treatment is also harm reduction, right? It's under the umbrella of, because receiving treatment reduces harm, reduces fatality. It is both.
That's fair.
Representative Merchant, you had a hand up earlier.
It's going back to the initial part, lines 4 through 6, 6 through 8. So we want to continue with the discussion about harm reduction before we move on, or?
Sure.
Okay. The issue, again, trying to wordsmith it here. What are your thoughts on it reading misuse of drugs, including alcohol, means using the substance in a manner or dose for a purpose that is not consistent with legal or medical guidelines?
I think that makes sense to me.
Thank you.
Representative Nagel.
Can I bring up like a conflict here? So I on purpose, most medicine is the practice of making simplicity out of complexity. My life is making the practice of complexity out of simplicity. So a lot in the world that I live in, there's not a lot of easily defined terms, and that creates a conflict when you bring it into a legal or legislative thing, and we're trying to define extremely complex issues with simple language. And I think it's an interesting dilemma. I really like the definition that we came up with. I think that works the best. Anyways, as far as the other issue, the prescription, it's really important to me personally to differentiate between prescription and other substances. I mean, to me personally, in my world, it's very important to differentiate between those two, and that's why I chose to do it. I will leave it up to your decision as to whether you want to do that or not, and we can talk more about this, but it's an important differentiation, again, for protecting the rights of the people that I represent, so.
Anything else with the department? Representative Leon.
Thank you, Mr. Chairman, and thank you for being here. I hear that you have a very broad definition of harm reduction and you want to have every tool available. How critical is the section that allows for use of the general funds to that program in order to increase your harm reduction services?
There, it is the ability to fund our harm reduction right now is, it does affect whether or not those are sustainable programs. So in places where the federal government has opened up available funding sources, we just need the ability to do that in New Hampshire to use those federal funds potentially. The scope of this legislation just makes that allowable, but there is not a particular funding source we would then begin using for those programs immediately.
Follow up?
And then thank you. As a follow-up, it seems that this whole program, especially with that focus towards the legal or medical differences, how does this work? I guess when you're looking at harm reduction and reducing the harm about everything except for convictions for having one of these substances, I guess I'm trying to figure out how you weigh all these other mitigation factors and keep the criminality as one of those crucial components when that stigmatization of the criminality is one of the things that leads to some of those negative outcomes.
This piece of the statute is around the Governor's Commission, which does include the commission makeup itself, includes the Department of Justice and Corrections. And so they do work closely on how we also change other pieces of statute around the criminality of substance use. But what the funding piece around the Governor's Commission does is specifically funding for the harm reduction of substance use in the space around public health and prevention, treatment, and recovery, and not within the legal piece around the criminality of illicit substance use, but it does include treatment, things like treatment prevention and recovery supports for folks who have been involved in the criminal justice system. Exiting incarceration is a particular focus of SAMHSA and the CDC because of the real increased rates of overdose post-incarceration.
Thank you.
Anything else with the department? Yes, Representative Nagel.
You're way smarter about this than me, so I run it. I'm curious, as I read this, I was, there's a two-part to this bill. There's the Governor's Commission, there's the Opioid Abatement Commission, and it seemed to me that by that language that, eliminated certain part, allowed state funds to be used, would that allow opioid abatement funds to be used for these purposes that it's not able to use now? That's how I read it, but I may be wrong.
The opioid abatement funds don't sit in the state general funds. I'm trying to think of exactly where they are sort of in the budget, but it could potentially open up the use of that funding source. I think the idea is to make sure that we have access to all of the funding sources if in fact there is that need, and applicate with the opioid abatement funds, people apply for the funding. And so if there was that need, and then it may be a funding source that can do something we can't do elsewhere. Right. So we have several restrictions, especially our federal funding sources all come with specific restrictions. And the opioid abatement funds, the best thing we can do for New Hampshire is look at all of our funding sources comprehensively and identify where our current funding sources have gaps and use the opioid abatement funds to plug those gaps.
Yeah. Yep. Thanks.
Representative McKay.
Thank you, Mr. Chairman, and thank you for your testimony. I'm not sure what part of the big department you represent, and if you could help us, because this is a complex issue, and I think you were sent up to clarify it, but I don't know who you represent.
I'm sorry. I am a policy analyst and the legislative liaison for the Division for Behavioral Health within the Department, Health and Human Services.
Other discussion? Anything else for the department? Seeing none? Okay, thank you very much.
Thank you.
So where do we stand with this amendment? Is it going back to OLS, or are we proceeding with a vote, or
I would think that we should do that.
proceed with a vote?
No.
Oh.
I'm sorry, yes, an answer question. Oh, well, I think we need
Okay, you withdrawing your motion to ought to pass? And who is the second?
I was second, I'll withdraw.
Okay. All right, so we'll wait for a new amendment addressing some of these concerns that were expressed. We have another amendment. That's all you have, Representative Nagel, right? Representative Leon has one.
Thank you, Mr. Chairman. I'd move that we adopt Amendment 2023-1621H for Senate Bill 239, and I'll pass that around.
Mr. Chairman,
Yes.
I'll second that motion.
Okay, thank you. Representative Land, do you want to speak to your motion?
Thank you, Mr. Chairman. I think that this bill tackles a lot of different issues, and I think we have one thing that's definitely very critical, making sure that we're able to have the Doorways program, making sure that we're able to have drug checking, and that we're able to get out on the street and do these quantifiable known harm reduction efforts. This is an area where I think I appreciate wanting to extend all of this harm reduction, but I still remain very, very uncomfortable by this broad and nebulous definition of any public health intervention that would reduce harm. Because there's a lot that can go into that. I especially am nervous with that, with Section 13, which we already in statute had the ability to use any federal funds that that we had the ability to administer and or disperse federal and other funds to syringe service programs authorized under this section. The section part that's being struck in 13 is the prohibition of use of state general funds. So in this bill, we both have the ability to use the Opioid Abatement Trust Fund and state general funds for all of the above type solution. I want to tackle this program, but I'd rather do it in steps as opposed to jumping off of a cliff and hoping my parachute was packed. That's actually one of these things. That's another topic I'm going to get into with this. So if you come to the bill, I'll let you know which ones I'm looking to remove. Well, I guess which ones I'm looking to keep. I think it's very important to keep the president of the New Hampshire Association of Chiefs of Police or designee on the commission. Then we have Section 8. Sorry, first page, line 17 through 19 is Section 2. So that would stay. And that's the one that puts the Association of Chiefs of Police. This would remove the broad language that's changing that definition from abuse to misuse that clearly is a challenge to define, and the harm reduction, which is also a challenge to define. That rather than trying to define that today, and then send it back just for a committee of conference as opposed to trying to have a larger dialogue on how to best define these terms. Quite frankly, it would kick the can down the road a little bit there, but I'm not sure that we're going to get to agreement on definitions of misuse or harm reduction. So my offer here was to remove those sections so that this whole bill and the good that can come from it isn't lost in that debate over definitions. So then we would keep the Association of Chiefs of Police on the commission. And then in Section 3, the organization of the task force, including prevention and harm reduction, is that blank check. It's that full definition that either is the one that people view as too narrow, or it's the one where it's any public health intervention. I think that loses focus when you're looking at everything, and I'm not comfortable with that. And with that language, this bill doesn't have my support. So in order to try and reach compromise, my amendment removes that section. Similarly, in Section 4, the task force, it has that misuse and harm reduction in there. As we roll into page 2, Section 5 has that harm reduction and misuse in there. So not being comfortable with the definitions, not being confident that we will find one that I'm willing to accept, I think that it's better to remove those sections. Then the meetings and reports also use that same language. So we get into page 3. Page 7 as well. Section 7 also has the misuse and harm reduction. Sorry, page 3. we're looking at a lot of bolded and italic misuse and harm reduction as we scroll through this. And I apologize that I'm going quickly. I'm just trying to figure out that right balance of speed and slowness. Now on page 3, line 19, I recognize that there's some challenges around the definition of harm reduction, but including some discussion of harm reduction along with treatment programs, I figure is a way to get things started and start discussing this in these reports. To not have a blank check to go whole hog on these, but that gets that discussion moving into that task force by speaking about the potential of harm reduction in their report for 8. I'm a little ambivalent on including that. I probably, if I were to draft this again, would take that section 8 out, but I'm trying to compromise and get to something where we can get agreement. So that's why I kept that part with the harm reduction. And now we get to what I think is very, very important about this bill. Section 9 on line 21 of page 3 is when we get into the syringe service program funding. It does say including harm prevention supplies. So once again, we're back to my definition, but I'm trying to find something that we can do to help people with these challenges. So this would allow funding from the opioid abatement funds for the syringe service supplies, which I think is a reasonable use of those funds. And then section 10, starting at line 26 on line 3, is the Doorways program, the substance use disorder access points. I think that that's done a lot of good. I don't want to lose that over the confusion of definitions. Moving to page, that stays in. Moving to page 4, section 11 would stay in. That's the part that is including criminal justice in the collaboration around the syringe service programs. Section 12, which is consulting and informing with municipal law enforcement agencies concerning the syringe service programs and harm reduction activities, that would stay in. That's important collaboration. Section 13, however, would come out. That is the one that removes the prohibition of state general funds. With an all-inclusive definition, that's too much for me to accept. Now we get back to what I'm keeping. Section 14, the syringe service programs. This is the one that allows the syringe exchange, but it also includes specifically that the funds being used by the opioid litigation law settlement can be used to support these programs. I think that makes a lot of sense. It also includes drug checking, and I think drug checking is one of the most important things that we can do in this state. Right now, we do not have a program that provides both more confidence to users that they're only using what they intend to use when they buy drugs on the street, so they're looking at greater harm. And we don't know from a public health or legal standpoint what else is in these drugs. We don't know if Trank is here in New Hampshire. I keep confusing that with a sweetener, xylitol or whichever it is. So I'll go with the street name of Trank. We assume that it's here because it'd be crazy to assume that it's not, but we don't know the prevalence. We don't know how much is contaminated with that. So I think that is absolutely critical. I think that's very important. I had kept 15 and 16, which were around the physician's assistants and the physicians and surgeons. But with our discussion earlier, I almost think that it would make sense to leave that in the hands of their authority to write the prescriptions for this. Because if there's already a program that's done in order to be able to write prescriptions for controlled substances, I don't think we need to duplicate that and then provide training that won't be used by people who don't pursue that license. So I would look to potentially have a couple of those changes, but I want to talk about why I think it's so important to be able to assess those risks by having the drug checking stations. If you don't know what risk you're taking, you can't truly assess that risk. I recognize that when you're chasing a high, your risk and reward ratio may be a little bit different than somebody who hasn't encountered that same challenge. I mentioned jumping off a cliff without a parachute. I used to jump out of planes for fun. And one of the big things we did every spring is we sat down with Safety Day. We'd talk about how people died in the previous year and try and figure out so that we and our friends wouldn't be those people that died. I'm a relative newcomer to the sport, but as equipment improved and as it wasn't equipment malfunctions that were killing people, we still had the same number of people dying. When something becomes safer, people take bigger risks. It's called risk homeostasis. And that is one of the big problems around mitigating some of the natural consequences of choices. If you jump out of a plane, you're not going to be able to break the laws of gravity. You need to make sure that you're prepared. And one of the biggest reasons to tell people not to use drugs is because, quite frankly, they'll destroy your life and your health, and they may kill you and the people around you. It's not a good decision to make, but taking away, basically making it so that everything wraps around you and supports you because you've fallen into this big challenge takes away a lot of the reason why people don't use drugs in the first place. And I think that that actually may be a cause of harm and not a harm reduction scenario when we make it too easy and too nice. Facing abuse is never easy, but we also need to make sure that when somebody is at a party faced with that consequence, they're saying, I've heard heroin feels really good, but I also know that the most likely way to get out of a heroin addiction is death. And I don't want to take that. It's not worth that risk, because it's that first decision about whether to use or not to use that really locks people into a path. I've known too many people with addiction. I'm just very, very cautious about stepping in too quickly into this massive harm reduction. I think that this amendment, we could do a couple changes to it about which sections, but I think that this amendment gives us the capabilities to meet this challenge without going too far. So that's why I brought this broad and sweeping amendment. And I thank you for your
Representative Seth King.
Thank you, Mr. Chair. And thank you, Representative, for offering this amendment. Before this amendment came, my vote on the main bill was a hard no. I'm not going to bore you with all the reasons why, I'm just a hard no. But this is such a huge amendment with so many different changes that, out of respect to the Senate and out of respect to Representative Leon, I feel like I couldn't vote on this right now. I feel like I would need to go home in a quiet space and sit down and really read everything that's been removed in order for me to, maybe enough of the things I don't like from the main bill have been removed that I could support it. But I couldn't do that right now. We just spent like an hour talking about some amendment that has like 2 lines changed, and now we're talking about potentially something that has like half the bill removed. So I appreciate the work which you've obviously put a lot into doing this, and I think that personally for me it wouldn't make sense to make a vote on that today. I don't know if we can do something to just like put this off and come back next week, but if this got passed today, I still would vote no on the bill because I don't fully know what just got passed with the amendment. It's just too much for me to sit here and talk about. I have to read it by myself. So thank you.
Other discussion, Representative Nagel.
Thank you. That's really very broad and thoughtful. I appreciate that. One comment, one thought. Both comments. I think everything, we talked about this before, this whole issue of defining things, and I threw out what I thought was helpful and what other people thought was helpful, but I think it does warrant a very large discussion on what those issues mean, and I appreciate that, but I think we do need to develop a format to do that if we're going to talk about that. The other thing that I wanted to talk about harm reduction is I've been involved with a national project for about 5 years at looking at athletics, and developed a concept called justifiable risk by, the decisions that people make when they decide to engage in athletics, which is not tremendously different from what we're talking about here. One of the things that became clear in interviewing people from all over the country is the concept of putting an adult in the room to make decisions. So I kind of look at harm reduction as a multi-tiered thing, not just the person making that choice, but then people at multiple other levels having some oversight or whatever, setting community standards, whatever terms you want to use to help people make wiser choices. I don't think it comes just down to that individual's choice. And I know that's simplistic, but that's what we came up with. So I don't want to narrow that definition of harm reduction too much to just that individual's choice. I want to make it broader than that. But I do think it's important that we go forward with an important discussion about these, and we could, this is a national issue. We could make a policy that would go to other states, whether they want to use it or not. So it's important.
Representative Merchant, then Representative Nettle-Upham.
Thank you, Chair. A question to Representative Leon. First of all, thank you for pointing out your concerns. Most of the concerns that I heard revolve around the word harm reduction. Almost every single section that you're looking to remove from this includes the word harm reduction. If we come up with a definition of harm reduction that we all can support, would that remove a lot of the objections to the other sections you're looking to eliminate?
Thank you very much for that question. I think I appreciate the work that Representative Nagel put into his definitions. I actually found that definition of harm reduction to be overly broad because that would include housing for people who had addiction issues. It would include so many different potential things that I think that it's reaching too far. I guess the question around that would be potentially a straw poll about whether people think that definition was too loose or too broad. And that would give us an idea of if we would reach some sort of agreement on a definition of that today.
Thank you.
Representative Nettle-Upham.
I must agree with Representative Seth King. This is far too much to digest to vote on today. As last week I said, can we read them ahead of time so we can think about them? I need to read it.
Representative Shapiro, and then Representative McKay.
I would also agree with Representative King that maybe we need to recess or come back to this next week since we're going to be meeting anyway. I do want to express my concerns about one of the things that Representative Leon said, which is that, or what I think she said, which was on the one hand, harm reduction is a positive because it keeps people from harming themselves more than they otherwise would. On the other hand, we need to keep the potential harms available to people because this is the thing that actually will motivate them to stop using drugs. So to me, those two things contradict each other dramatically. And I believe in harm reduction. So I'm concerned about, this is different than taking more time to kind of digest the amendment. But I just want to express my concern about making sure the potential harms and risks remain, because those are going to be the things that get people off drugs. And nothing is black and white, but I guess I don't agree with that.
Well, Representative McKay, and then Representative Kofalt, then Representative Leon.
Thank you, Mr. Chairman. What concerns me is the changing the Governor's Commission on Alcohol and Drug Abuse Prevention, Treatment, and Recovery. I was once a member of this committee. It seems to me it's been well organized and well run for many years. And I have some grave concern as to how we got to this based on what we've been discussing. It seems to me that this is changing something that is well established, and I don't hear anybody that has talked to the Governor's Commission as to the need for change. So I'm very concerned about that part of it.
Yeah. Representative Kofalt.
Thank you, Mr. Chairman. So, I mean, I do want to sort of remind people. There was one statement made in the testimony on this bill that really stands out for me, is that, you know, someone saying that people come to me and they say, the syringe service program saved my life. So I think that is something I'm trying to keep in mind as I deliberate on this one. At the same time, I do have these serious concerns, and I think that the definition of harm reduction as the vice chair has pointed out, it's still a very broad definition, and I'm not even sure we can agree on whether harm reduction and treatment are two distinct things, or whether harm reduction or whether treatment is a subset of harm reduction, as we heard today, whether they're two separate things, as we heard in the hearing, or whether harm reduction is a subset of treatment. As if you read the bill, it talks about treatment, including harm reduction. So I think that there's a lot of real fuzziness. I think a lot of the people who are talking about this sort of have an idea of what they know, what they're talking about. But I think that when it comes down to it, it seems like there is a tremendous lack of clarity around what these things mean. And if there is a successful program in place, and if people are saying this saved my life, that's great. We should continue to do what we can to save lives. My concern is that as we change that, as we expand that, let's make sure that we're doing this properly, so that we're not opening the door to something that nobody's really clear at this point what it is. So that's my concern about the bill. I support the amendment because I think it removes a lot of that lack of clarity, or a lot of those areas that are very unclear.
Representative Leon and then Representative Nagel.
Thank you, Mr. Chairman. The first that I want to say is I was trying to do something so that I could support the good that's in this bill. I received the language of this amendment at 9:25 a.m. And it just picked it up from upstairs. So sorry that it was so late. To Representative Shapiro's point, I'm trying to make sure that we do have the syringe exchange and the drug checking in place, and to have some taxpayer-funded harm reduction efforts. I think that that larger conversation, part of that question is how much of that comes from taxpayers where we're authorizing any sort of harm reduction, and how much can come and potentially through private funding or something else, show that other modalities of harm reduction do actually reduce that harm and lead to less drug use, as opposed to just changing the course for people who are using drugs, or potentially increase drug use. So I think that we need to be careful of those consequences. That's why, instead of just opposing the bill, I'm trying to figure out how to have the syringe service programs and the drug checking in here. And then Representative McKay, my amendment actually reduces the changes that are being made to the commission. It does keep that change with having the police chiefs in there, but otherwise I remove most of those changes to the commission.
Representative Nagel.
I guess I had a question then for Representative McKay. Were you referring to the entire bill, or just the amendment, or that we're dealing with now?
May I answer that?
Sure, go ahead.
I'm very concerned about the amendment which modifies the membership and reporting requirements of the Governor's Commission on Alcohol and Drug Abuse. That part of it.
It seems to me that that's the bill, though, not the amendment.
I'm not sure I understand.
It seemed like you were happy with the way things are, and you didn't want to see any changes. Am I wrong about that?
I'm not very happy with any part of this, but I am concerned about changing something as significant as this without going into some study beforehand. It just seems to be an afterthought, and I would like to, I don't see any need to modify the Governor's Commission as it is in the first place. But if we were to do that, I think that this bill should be retained.
I just wanted to, if I could, the reason why the bill was brought up was, to me, twofold. Number one, I was involved in the Department of Health and Human Services interagency task force on creating a unified statement on pain management that involved 13 different federal agencies. It was really entertaining at best, mostly to just keep the acronyms straight. But what I've also been impressed with in this state is that we're seeing increasing numbers of agencies that need to work together. And I think that one of the reasons that this bill came is, number one, is to allow them to coordinate their services better. And Jennifer, tell me if I'm wrong, but, to coordinate their services better, use up-to-date and unified nomenclature, And if you look at the governor's, that you were on, the governor's commission on alcohol and other drugs, there's a very well-defined section here on harm reduction. So as we went forward with the opioid abatement commission, that was one of the things that was asked if we could include that in the opioid abatement commission. So including harm reduction in the terms was important, and that's why it was added. I totally understand the concept of defining what that means, and that's a challenge, and maybe we should spend more time on that. But that's why those changes were made. It wasn't to recreate any wheels. It was done to actually improve the interaction of different agencies together.
I think that responds to my concern that this is leading to significant changes that I am not believing that that this commission is not fulfilling its responsibilities. Yeah.
Representative Floyd?
Lloyd.
Lloyd,
yeah.
I'm sorry.
Hi. As a substitute and knowing that I may not be here when this is again discussed, I would just like to throw out there, I did appreciate the note about specific to the licensure changing, possibly impacting like veterinarians and those types of services. And I just urge the committee to really be very careful about DEA licenses and the process to get those specific to animal welfare agencies. I know that drugs like ketamine, xylazine, those types of things are used in procedures to sedate animals. So I just keep that in mind, please. Thanks.
Thank you. Representative Shapiro.
Obviously, this has become very complicated, and it's so one question I have is whether to put this off till next week and refine some of these amendments, or to retain the bill so that it can be worked on over more time and with more depth. But I'm unsure about what the urgency is from the Department of Health and Human Services if we were to retain the bill, and what the consequences would be. I know there's some things about funding for some of these services. So I wonder if we could hear from them about what the consequences would be of retaining the bill, so we can have all the discussion that people are saying we need.
I mean, keep in mind, we've already have quite a few retained bills, but yeah, could somebody from the department come forward and address this?
Jenny O'Higgins. I'm a legislative liaison for behavioral health for DHHS. So this bill did come from Representative Waters, who sits on the Governor's Commission. The Governor's Commission is after the study committee on harm reduction. The recommendations came out of that legislative study committee on harm reduction and were discussed with the Governor's Commission. So it's not a department bill, but it would be really helpful in opening up the funding to help make sure that we have every tool in our toolbox to curb overdose and be able to get more upstream in our prevention and intervention services.
Okay, thank you. Representative Nattarapan.
So, is the funding that you're talking about just federal funding, not state funding? Because I think that's a concern always.
The scope of the legislation opens up harm reduction services to availability of state and federal funding, which would include abatement and Governor's Commission funds, neither of which touch general funds, just specifically would open up these other funding sources that are available to New Hampshire.
So what do you view as the biggest consequence if we do retain this bill?
We just have less available funding for the potential of these harm reduction services.
Okay, for like another year until we pass it.
Right. So the opioid abatement funding in particular has allowed the state of New Hampshire to fill gaps in current funding sources. And the purpose of making sure that we can also fund harm reduction services is to reduce overdose fatalities.
Okay, thank you very much.
Representative Leon, did you have your hand up?
Thank you, Mr. Chairman. So it sounds like there are no current funding requests in. So if we were to take this up and it came to the floor in January versus May, there wouldn't be a direct impact. It would just be about future requests. Is that correct?
There are current requests in for harm reduction services. Actually, today at GNC, there are the first 16 of the opioid abatement grant agreements are at GNC today. So that the opioid abatement funds are beginning to move at this point, and the Governor's Commission already has been doing this work for a number of years. So that the funding is in motion, and the expansion of availability of funds for syringe services programs is the scope of the legislation before you. The availability of that funding to go to that specific harm reduction program.
Representative Nagel.
Just to expand on that, I mean, one of our big tasks right now is to solicit more grants. And that I would assume would affect what types of grants we could solicit at this point. So that's a now thing. Am I
Yes.
correct?
Yes.
I mean, we're meeting on Monday to talk about that, so that's important.
Representative Merchant.
For clarification, this RSA governs the abatement program, or the abatement program has its own RSA under its own guidelines? I'm getting confused here between what role the abatement program has in its funding mechanism and what it's allowed to do versus this bill interfering with that. So I'm not sure exactly if one's going to augment it or one's going to displace it. Can you help clarify the role of this bill versus the role coming from the abatement funding program?
I apologize, I don't have the bill in front of me to point you to the specific sections, but there are sections of the legislation around the Governor's Commission, sections of the legislation around opioid abatement commission, and then sections of the legislation around harm reduction syringe services programs that allow for the available funding to be used for those purposes in any of all state and general funds. And so, I'm sorry, not general funds, federal and state funding. And so that last section around syringe services program is the piece that opens up the availability of those other funding sources I was mentioning, which are other sections of the bill.
Thank you.
Representative Nagel.
Senate Bill 32 that we passed, that was the big addition, was harm reduction. And so that was adding harm reduction to one of the 17 potential items for soliciting funds from the Opioid Abatement Commission that was not in there before.
Representative Merchant.
Again, I'm really lost. So on Senate Bill 32, which we passed, that deals with the use of the abatement funds, which includes harm reduction.
That bill added, there's 17, or there were 16 entities by which you could solicit funds, or, you know,
Right.
solicit, or put a grant in, whatever. Harm reduction was added as part of that bill.
So
So that's now a reason why you can ask for funds. Well, it's not yet, it has to pass the governor, but.
So go back to, again, the same thing. If we retain this bill, there's nothing to prohibit somebody from going to the abatement program and asking for grants
Correct.
for harm reduction.
I don't know.
Well, there's that last section of this bill around syringe services that say that state funding cannot be utilized. And so the abatement funds are state funding.
Yes.
And so it is making sure that while today programs can apply to the abatement fund under that are harm reduction programs, we have in statute that syringe services can't receive federal and state funds. And that's the change being made in this bill before you.
Representative Palmer.
So my question is, listening to Representative Leon's amendment, would her amendment, if that passed, would that work? Would that enable these funds to be accessed? Maybe you have to look into that a little bit more, but that's sort of like seems to me a key question.
Yes, unfortunately, I just would need to review what those parts of the bill that are the sections that are being removed a little bit more in depth before I felt like I could answer that.
Representative Leon.
Thank you, Mr. Chairman. And thank you. As you look into this, to me, it looks like the big key in this is Section 14, the Controlled Drug Act syringe service programs that allows the federal funds to be used for drug checking, drug cracking equipment, drug supplies, eligible activities, and that provides that permission in order to use those funds. That to me is the most important part of the bill, and that's what I was looking to preserve. I know that you speak to a prohibition on syringe services for state funds. However, Section 13 that strikes it just prohibits state general funds. It doesn't prohibit any of these other special funds. And so I would be very interested to know if just that Section 14, if we pass just that, if that would get us through to be able to introduce a bill in the coming year to then address the rest of these issues and not hold up a pressing need to offer greater services and access that funding in order to deal with these more esoteric parts. So.
I wish I had a very direct, clear answer for you today, but it is something I feel like I need to review further.
Yes, Representative Merchant.
Thank you. I'd like to call on Representative Wallner, who's from the finance, probably understands this better than I. My understanding, the way the money is flowing from the opiate abatement programs go into a designated fund, not into the general fund. So therefore, the question from Representative Wallner is that if the funds from the abatement program are going to a designated fund and therefore not to the general funds, is in fact on page 4, lines 18, about the use of general funds, how does that impact? Because if they're not going to the general funds but to a designated fund, is that in fact outside of the general funds?
Could you use the microphone, Representative?
I've been trying to read it on my phone, so it's a little hard to really see it. I mean, what I see in the original bill that you have, what it looks like to me is what that they were proposing by striking out the use of state general funds. They struck that out, that prohibition, and would allow any, it looks like any state funds to be used for this purpose. And I would ask the attorney if that is her agreement with that.
So my expertise is in behavioral health, and I'm not an attorney, so just want to clarify. That again would just have to be a question for someone with more familiar with the general funds.
Okay, thank you.
Representative Kofalt.
Yeah, so I believe that the question was asked of the primary sponsor, why that section of statute would be stricken in this bill. And the answer we heard at that time was, well, we just thought it was a good thing to do in case we want to use general funds in the future. And that was put in order to pass the original bill, but I think everybody recognizes the value of syringe services at this point. So, forgive me if I'm not remembering that with, precision, but that was the general gist of his statement. And, it seems to me that would align with the statement that, allowing for use of the opioid abatement fund would not be prohibited if we were to restore that language or to remove that section that would strike out that language from statute.
Okay, any other discussion? I'm seeing none. We have a motion on the floor, but I'm hearing mixed signals here. Representative Leon, it's your motion.
Thank you, Mr. Chairman. I'm thinking that with all these moving pieces and with knowing that the next big one is large, I was wondering if we could just recess for an earlier lunch. That way we have time if anything was going to go to OLS, and that way we can sort of think about if we can get some answers when we come back from lunch about whether that section 14 on the syringe program would be enough to get us through to next year, just to get some information on that, so that we can have a little bit more information before we move. That would be my suggestion, but I'm
Will an hour's lunch be sufficient, or do you think we need more time than that?
It would probably be sufficient, but I'm not sure if anybody else has other lunch plans, if we should come back at 1.
Any thoughts on this? Does that seem to be a potential solution? Representative Nutter Upham.
don't think an hour is going to get us where we need to feel comfortable about voting on this amendment or not. I would prefer to table it to next week, and then we can decide whether we're going to retain it, and prefer to move on to the next bill and be done earlier. But anyway, that's
Representative King, you had a similar concern. What do you think about this?
I don't know. Upon more studies, while everybody was talking, I don't think I'll be able to support the main bill, even if this amendment were to pass. So on the one hand, I think to myself, well, I should vote for the amendment because it makes a bad bill less bad. On the other hand, I don't want to necessarily help the bill get passed. So I'm in a quandary. It's a political quandary, I know, but I don't know. Take that as you will. I always will vote for longer lunches, though, because I am the slowest eater here. So thank you.
Okay, well, yes, Representative Merchant.
I would support to table this until next week, but also I would like to be sure that during the time that we're tabling this, that we don't just wait until next week to continue the conversation, that we actually have a group of us sit down and talk about it. But more importantly, before we even move forward, I'd like to get clarification about the language on page 4 about the general funds versus the use of opiate funds, because if that is not the case where opiate abatement funds can in fact be utilized in that capacity, then we could possibly even retain this and work on it for a longer period of time. So I guess my question to the chair, how do we find out, who do we speak to find out in fact that opiate abatement funds are not considered general funds, they're outside of it? And then at that point in time would help me make the decision whether to retain this and then move forward sometime next fall.
Good question. Representative Nagel, let me think about that. For a minute.
There's multiple vehicles to answer that question, but we have a meeting of the Opioid Abatement Commission on Monday. I can certainly reach out before that to the person who really knows a lot about that stuff before that. I just wanted to bring one other point up. I'm a new legislator. I do not feel comfortable in making new dramatic changes in language to an amendment on the fly. I just don't think it's good practice, so I would rather table too.
Okay. Representative Murphy?
No, I would echo the same sentiment. I wouldn't say totally confused, but I am somewhat confused with all the different changes that we've talked about. So if we had the opportunity of seeing the amendments that that Representative Leon came up with, but also the opportunity to perhaps work with Dr. Nagel about tweaking some of his language as well in his 3 amendments. Having that in front of me over the next week would be so much easier for me to digest and understand, and I think we would save a lot of time doing that.
Okay. All right, the motion is on the floor. Representative Leon, what's your thoughts?
I can withdraw my motion.
Okay. Who seconded that? Representative Cushman, and you withdraw also?
Yes.
Okay, so the sentiment is to continue this until next week. Is that correct? Okay, we'll continue Senate Bill 239 until next week.
Do we need to like create a subcommittee, or do we just leave that as random discussion? I don't think random discussion is a good idea.
Representative Leon, did you want to speak to that?
Thank you, Mr. Chairman. If it's a ad hoc group of some number of people that are less than a quorum, there can be some discussion in order to address those problems and bring them back to the larger group.
Right.
We can't have discussions as a group outside of these public hearings because that's our transparency. But we can have people go and reach those targeted things. We can send an amendment to the people in the group so that they can see it, but we just can't have discussions
I
outside.
gotcha. Thank
This
you.
is an early bill, by the way, so one way or another, we need to make a decision next week, whether it's retain or other action. Yeah, Representative Merchant.
Again, for clarification, to follow up on Representative Leon, if this is an ad hoc group and it's not a quorum, not enough members of the community to create a quorum, are we permitted to meet via Zoom virtually versus being in person? It would make it easier, I think, for some of us.
I would say if it's Ms. Dyer might be able to advise us better on this, but if it's an informal group, I would think a Zoom would be feasible. Am I right about that? I am right about that. So. Okay, any other thoughts on Senate Bill 239? All right, we will continue that until next week along with 240. And moving on to everybody's favorite, although at this point, we know this is going to be a long discussion. Do we want to break for lunch and come back? And again, what you're talking about, is it going to be able to resolve in an hour? Or should we just go to one to, balance it out?
I think that there's a lot to be discussed here. Unless we're planning on keeping our discussions to just a short time and then adjourning at, say, 1, I think it's better that we get some sustenance for the discussion ahead.
Okay.
Representative Shapiro.
Representative Shapiro.
I would just like to second that opinion. I would personally, since judging from the discussion about the last bill, the discussion about the next bill could go on for some time. So I would like to break for lunch, but not make it an extended lunch and siesta, so we can get back as soon as possible.
12:45? How does that work? Okay, we'll break for just a little over an hour. We come back at 12:45. Thank you.
Good afternoon. We're back. A few minutes late, but we're back for the afternoon session. We have covered as much as we're going to today, the four of the five bills that were noticed in the calendar. The one remaining bill for us to consider this afternoon is Senate Bill 263. And at this point, Representative Leon, did you have a motion?
Yes, thank you, Mr. Chairman. I move that we retain House Bill 263.
And Representative Cushman seconds. You want to speak to your motion?
Yes, thank you, Mr. Chairman. There's a lot of confusion around Medicaid and Medicaid expansion. We've received hundreds of different emails, and a lot of them are actually talking about people with disabilities, children, other groups that are covered by traditional Medicaid. So I think that that's one area of confusion where we need to make sure that we understand what it is that we're dealing with here. There's also a lot of confusion about how this is in the statutes. So right now, Medicaid's in a state of flux because we're unwinding the public health emergency. We have this language, even with all of its flaws, in the budget. It has a sunset in the budget, and I support that. I support our position that's in the budget, and I think that that's the right place for something of this magnitude if we're going to keep moving this forward. I truly think the best place for this bill is in our committee, working through the summer and the fall and looking at the fact that our statutes, about half of the language of 126 AA is actually expired because it says on or before this date, we must do X. It shows that there were reasons why we needed to put in requests for waivers and other things that were conditional and based on a time frame. This is something that encourages having a renewal date and having a sunset, because a lot of people here probably don't want to touch the hot potato of Medicaid expansion. If we weren't up against the sunset, I can guarantee you this wouldn't be in front of us. But our job here is to do the challenging, difficult work of looking at our programs and making sure that they're operating as we expect. So as we look at this, our current law lives in a couple places. There's 5 sections in 126 AA. And then there's some that's in chapter law. Of course, it's hard to tell which parts of chapter law are still in effect, because as I was digging into all of this, in 2018, the chapter law that stated that there was an expiration based on federal funding was revising chapter law from 2 previous times. The idea of having something of this magnitude sprinkled across not just the RSAs, but also chapter law makes a confusing issue even more confusing. And passing this bill as we have it does nothing to solve that clarity issue. Then there was also the ones where we had a law that had a waiver request. Recent history has shown that when the legislature wants the department or any department to submit a waiver, we need to put that in writing and we need to put that into statutes. That's one of those things that also gives that emphasis for them to pursue that waiver, and perhaps may give a little bit more heft when it's received down in DC, because it's not just a department, it's the department at the behest of the legislature and governor making that request for a waiver. If you look across the country at the whole Medicaid program, it's a system built upon waivers. So just because we're asking for a waiver for this, that, or the other doesn't mean that we're not following the law. It's what it's based upon. And so I really believe that this committee is the best place to work on this. You know, we're the ones who understand what people are going through. We have medical professionals who have seen both sides of the benefits of having patients with Medicaid and some of the challenges of serving people with Medicaid. We have people who have constituents who are talking about services. Now, I actually found out that we had a sterilization bill earlier about that right. I found out in New Hampshire, Medicaid will not pay for a hysterectomy unless you're over 37 or have children. Now, that's the sort of thing we can fix when these things come up, but it's very, very hard to do without having a sunset. And I guess one other part that I do want to make clear, because it is so challenging, is the difference between Medicaid and Medicaid expansion. If you have disabilities, you are on Medicaid. That is one of the waivers. If you're a kid, you're on the Children's Health Insurance Plan, which is rolled into our traditional Medicaid. Lower income families are in traditional Medicaid. And retirees that need a supplement for long-term care are on traditional Medicaid. None of those are up for this discussion. That is something that is in federal law, we've agreed with, and we're going down that path forever hand in hand till even past till death do us part, because this survives all of us. But Medicaid expansion is that creation that came about from the Affordable Care Act. It was a way in order to figure out how to bridge that gap and provide government paid health care, because if you were going to force people to get coverage, you had to provide a solution. It took us a long time to get to the point where we are here in New Hampshire. We had walked through a couple different pathways, but as we walked down those pathways, we figured out what we needed to do in order to get to the next step. But I don't think this program is as strong as it could be if we really worked together in order to figure this out. And, lastly, I also want to talk about, there's a lot of efforts to increase the minimum wage. There's a lot of efforts to make sure that people are being paid a living wage. But when you look at the cap on Medicaid expansion at 138% of the federal poverty level, when you take away the 5% holdback, that means that for a family of two, they can't make more than $27,213.60 a year. So that means that if both of them were working for 100 hours a month, which would be the work requirement if it's reinstated, they couldn't make more than $11.34 an hour. So in order to qualify for these benefits, you're being locked into lower income work. And that's a really, really difficult position to be in. So then if you had both of the family members in that two-member adult-only household working full-time, well, unless they were servers who didn't get good tips, they couldn't. Because if you're making $7.25 an hour, the federal minimum wage with two people in the household, you don't qualify for that. So we need to look and see what it is that we're doing. So I have a number of different solutions to get us closer to our right path. I mean, when you look at this, it's a program that really keeps people stuck in order to meet a need, which is healthcare. And we can't just pass this into the future with no sunset and let this keep going without taking on the important task of trying to make this better, trying to make it stronger, and also trying to make sure that we ask for what the people of New Hampshire need. If you look at this, we basically had rules passed down from DC as to how our hospitals could operate during COVID because of the threat of the loss of Medicaid money. If we had had a position of submitting waivers for anything that's contrary to New Hampshire law, we may have kept some more healthcare workers by having more flexibility. And I think that this is our opportunity to look at this. So what I would suggest doing is, we have a couple different amendments on these. We're not really going to take them up, but I want to discuss the different issues that we have with the program and sort of concretely tell you how we could fix it. So it isn't just this esoteric idea where we sort of talked around each other last week. Because just like the last bill, there's good in this, but there's a lot that can be improved. And I think that we probably should take some time to do that. So I'll probably ask to be recognized later on, but I think I've spoken for a long enough stretch of time. Thank you.
Representative Shapiro.
I'm going to vote against the motion to retain the bill. Not only did this pass the Senate 24-0, the business community supports this bill. The healthcare providers support this bill. This bill has provided healthcare to approximately 60,000 Granite Staters. The information that Senator Bradley gave when he introduced the bill talked about the amount of churn among people who have been on Medicaid expansion. In other words, people did not just remain on Medicaid expansion and become dependent, that it actually supported people's resilience and allowed people to be healthy enough to go to work. I could talk for a long time, and I'm not going to talk anymore, but I would hope that we could have a vote fairly quickly about this so that we can get on with the discussion about what, if anything, we're going to change.
Representative Palmer.
So Representative Shapiro started with the first several of my reasons why I will vote against retaining the biggest ones are, in addition to the Senate voting 24-0, every single comment I've had from my constituents has been in favor of passing this bill. Our hospital system is at a crisis point. This is a key piece for now, regardless of whether you don't think our current medical system is a mess. I completely agree. But if you try to take it apart piece by piece, it's just going to collapse right now. And there'll be at least 60,000 people without health care if we don't pass this. And there'll be, other disruptions in the medical system that will affect more people if we don't keep this going. So I think we need to move forward in a way to make sure that this becomes law this year.
Representative King, Seth King.
Thank you, Mr. Chair. I think to address both representatives' concerns, the fact that it was overwhelmingly passed in the Senate, much to my chagrin, Medicaid expansion is popular. It seems pretty popular. So I think what that actually says to me is that you need not fear future legislators or legislative bodies getting rid of Medicaid expansion if it is as popular as we think it is. But the permanency is, I think, dangerous really for any program. I don't think I would support permanency for any sort of program. Let the legislators next session deal with these things. So that's my stance. It's a popular program, even though I don't personally like it. And I don't see what the fear is of just letting it continue on normally. Thank you.
Representative Cushman.
Thank you, Mr. Chairman. I understand that it did pass the Senate 24-0, but we are our own body and we are elected by our constituents to vote how we believe we should vote. And there are, after combing through this program, there are so many things in it that are not, I don't see them as being the New Hampshire way of doing things. It seems that it's just we took a cookie cutter federal program and put it into our laws. We've heard the statements that there are protections for taxpayers in this, but perhaps it's in chapter law, but as it's written right now, that in the RSA 126 AA, in section section 3 Roman 6, that severance clause where you've been told, well, we've heard that if the federal government stops paying their 90% share and they reduce it, that the program ends. Well, that's actually not what it says there in the statute, and it's been changed. And I actually have a paper which my caucus has. So if we could pass some of these out to the other members of the committee, that would be wonderful. Shows the evolution of that text since about 2014. So there have been, it's been kind of chipped away at over time. And now really the only way that this program will be, if we don't have the money in the trust fund, the Granite Advantage Health Plan Trust Fund to cover it, it used to be that there was a trigger, if it went under 95% by this year, then 94% by this year, down to 90% of where it was, and I believe 2019 was the last year. That's been removed completely. Now the RSA only says that if there's nothing, if the commissioner finds that there are not sufficient funds in the Liquor Commission fund to cover a shortfall, then the program will be terminated. And that Liquor Commission fund, that's literally the Liquor Commission's budget. So unless the Liquor Commission goes bankrupt, which would indicate that the state of New Hampshire is in very dire straits and probably the entire country's economy is in shambles, the program, there is no safety valve for that program to be, responsibly terminated. So the language that was supposed to be in there to protect it is not here in the statute. And if it's somewhere in chapter law, I was not able to find it. So to me, it looks like we don't have that protection, and that's a big problem for me because the federal government, the Congressional Budget Office has stated that it recommends that that Congress increase the Medicaid rates, increase the state portion of Medicaid. So they'll be looking for us to pay a bigger share of this eventually. And if they change it, it looks to me that there is no clause here that allows us to back out of the program without taking on that extra financial responsibility that we didn't agree to. So I would like to see that changed. There are issues with this commission and, you know, the way that this is funded, I don't see it going into the budget. In HB2, there's some language that it will be in the budget going forward so that it can be looked at like everything else. I'm just going to bring up the language specifically. But this is missing from this bill. So I'd like to see what's in HB2 go forward. We retain this. Maybe we add that clause and fix some of these other issues first. But that language that I'm talking about states, sorry. Of course, it's not going to come up now. Well, it doesn't go through the normal budget process. So we want it to do that. Another issue that I found, not this one. That's the shortfall. The work requirement. So we've seen that there's been some movement on that. Georgia has now managed to get a work requirement for Medicaid in their state, the details of which I have not had the chance to thoroughly dive into. But I think that there is an opportunity here and that we should be requiring the commissioner to submit a request for approval of our community engagement requirements that are in statute. These are things that make the program tailored to the values of New Hampshire. You know, we want those protections for taxpayers. We want to keep a responsibility aspect in this program. And if we can do that the New Hampshire way, it should be done that way. We don't do things like every other state. We do it our way. And that's why we have the New Hampshire advantage. There are other issues that I can touch on as things move forward, but the bottom line is there are a lot of holes. There's a lot of room for reform, and I don't think that we should be making the program as it currently is permanent. I think the 2-year sunset is perfectly reasonable and is enough time for people to come together with. Now we have a lot of great ideas and a good jump off point to make this program tailored to our values here in the state. Thank you.
Other discussion? Representative Merchant.
Thank you, Mr. Chair. I will be voting also to not support retention of the bill. I think I could speak to a couple of concerns that I heard. One is about the budgetary process. My understanding is it's probably going to go to finance, so therefore it's an appropriate way to be vetted through the finance, which is a budgetary process. I do support Representative King's comment. It's a popular program. But then you ask the question, why is it popular? Because it actually helps a lot of people. And I heard from the business community, it helps them as well, bringing down premiums. And if you're looking at trying to find ways to encourage employers to offer health insurance, one of the ways to do that is to bring down the premium cost because they can afford to give it to their employees without having high deductibles. I do want to bring out the fact that in Sullivan County, which I do have here in front of me, in Claremont and Croydon, by itself is over 1,700 people that are benefiting from this program. Also within Sullivan County was $60 million added to the coffers of providers and so forth. I do understand where Representative Palmer's coming from. We have a very precarious situation right now after COVID. A lot of the hospitals are struggling. They are literally on the edge of going under. And if we don't find a way to help them, because ultimately they still get care, folks. They just show up at the emergency room. which is uncompensated care, or rely upon the providers to provide uncompensated care to them as well. What that creates is a pent-up demand because we don't take care of things early on. The old adage of an ounce of prevention is worth a pound of cure. And I think the same thing goes through here, that we have to be sure that patients fundamentally have the opportunity to get the preventative care they need to keep the costs from getting out of control. So for all those reasons, I will be voting against retention of the bill. Also, but if I can, the question about working on this over the next 2 or 3 years and retaining it, that's the role of the commission. I mean, the commission is being created to fundamentally help guide future legislation. So if that commission is doing what it's supposed to do, which I think it will, it's going to help guide our legislative policy to make sound judgment legislatively going forward. So Representative Leon, I hear what your concerns are, but we don't need to delay it. We actually are putting something in place to help guide us in the future.
Other discussion, Representative Cushman.
Thank you, Mr. Chairman, and thank you, Representative Merchant, because you helped me remember another point that I wanted to make. I understand that, you know, the healthcare system was facing uncompensated care, and that one of the goals of Medicaid expansion was to help deal with that, to help people get primary care before they have to go to the hospital, and, you know, reduce healthcare costs that way. And, you know, a lot of people talk about the benefits of the program. You know, we've reduced costs here. We've, this has improved, but no one really talks about the costs of the program compared to those benefits. And, you know, the MCOs get a capitated rate. They get paid for every person who's on the Medicaid rolls. And this program costs a lot of money. And I would submit that it costs a lot more money to run the program than the uncompensated care of all of the hospitals each year. And if that's the case, then maybe this is not the most financially responsible way to do this. And I think, going back to my point about doing things the New Hampshire way, that maybe a voucher system for primary care for indigent individuals, or, a baseline. There's another way we could do this, not necessarily, maybe Medicaid is the best way. But I think there's room for other ideas to deal with this that could be much more cost effective, and that could be tailored to be run the way that I think, historically New Hampshire residents seem to like things, to be very fiscally responsible and tailored to how we do it here. So that's just, bottom line. If this is costing more than the cost, the uncompensated care that we were looking to cover, or if it's costing more than, a visit to a primary care doctor for each of the people in this enrollment plan and, their healthcare needs, then it doesn't really make sense. And I think that there's a better way to do this, and that more discussion definitely needs to take place, and we shouldn't be making it permanent today. Thank you.
Representative Cannon and then Representative Palmer.
Thank you, Mr. Chair. I represent the small city of Somersworth and the small town of Rollinsford, and those people elected me to represent them. And the overwhelming amount of mail I've received associated with this bill is to pass it. You have to remember, we have communities that are extremely low income, and that's a big challenge for us in Somersworth. We have a lot of city supported housing right now, and many of those people are on Medicaid. We don't have a whole lot of people making over six figures in Somersworth or Rollinsford, or even in the high double digits. It's just a way of life in our communities. We got to help our community, and this bill will help our community. Thank you.
Representative Palmer and then Representative Leon.
So the other thing about making significant changes, this program is a federal program, and they're paying 90% of the bill. And I run up against this all the time, which is that you want to fix something, but you can't fix it at the state or local level. It's got to be fixed in Washington. So a lot of the things that Representative Cushman and Leon are talking about need to be fixed there. We can't change a federal program in New Hampshire. We can decide whether or not to take it, but I think we have to realize that if we're going to take it, we need to take it with its rules and try to adapt as much as we can within what the federal government will allow, but we aren't going to be able to make this a New Hampshire program.
Representative Leon.
Thank you, Mr. Chairman. I think that one of the important issues about having a sunset is keeping that pressure on DC and on the federal government to keep this as a program that is responsive to the needs of the states. The more states that sign on in perpetuity, the less pressure there is in order to keep it focused, and the less pressure there is in order to make sure that it stays at its intended role, as opposed to going for a big scope big change in scope. I apologize. I should have had more than coffee for lunch. One of the other parts that I did want to hit upon was the discussion about the commission. So initially, when the commission was created in 2018, it had generally the same makeup. However, the only voting members of the committee were the 6 legislative members, and a quorum was 4 of those 6 legislative members. Now, the voting members are 3 members of the Senate, 3 members of the House of Representatives, the Commissioner of DHHS, the Commissioner of the Department of Insurance, a representative of each managed care organization awarded contracts under this, a representative of a hospital that operates in New Hampshire, a public member with healthcare expertise, a public member who currently receives coverage through the program, a public member representing the interests of small business in New Hampshire appointed by the Chamber of Commerce, a representative of the Medical Care Advisory Committee, Department of Health and Human Services, appointed by the Commissioner, a licensed physician appointed by the New Hampshire Medical Society, a licensed mental health professional appointed by NAMI, a licensed substance use disorder professional appointed by the New Hampshire Alcohol and Drug Abuse Counselors Association, an APRN appointed by their association, the chairperson on the Governor's Commission on Alcohol and Drug Abuse Prevention, Treatment, or Recovery, and designee. And I believe that there's also some effort in order to include Josiah Bartlett Center and a pharmacist in this as well. But when you look at this, if everybody there is a voting member, you have a lot of the groups that benefit directly from this and few of the groups that see the indirect harm. This is a program that the more that it's expanded, just about everybody who is part of that commission, they benefit. And I was an analyst on Wall Street. Of course you act in your own interest and the interests of those people you represent. You know, I don't think that it's a negative that people are advocating effectively for those people who they represent. But I believe as a legislature, we need to make sure that we aren't creating commissions that are stacked for one outcome, as opposed to being able to look at both the benefits, the risks, and more specifically, how we can craft legislation to be more New Hampshire specific through the waiver program that does exist and is used robustly in the state. I'll probably ask you to come back. I might wander if I get to my next topic.
Representative Shapiro.
Thank you, Mr. Chairman. I would just like to say that I don't think any of us are going to convince any of the rest of us about whether this is a good idea or not. And I would implore our committee to just take a vote on it.
Representative Leon.
I think that without addressing the significant underlying programs, we miss a very large opportunity in order to see what can and should be improved. For one thing here, we have in statutes a reduction of polypharmacy resulting in drug interaction harm as part of the Granted Advantage program. We see significant harm from polypharmacy. A lot of the mass shooters are on polypharmacy. We need to understand how much that's happening within our Medicaid system, and so that we can at least have a subset of data and understand what risks we may be encountering. As an analyst, I looked to Sweden, and they had a lot of great population level data, which let us get an idea of trends, the way things worked, and what we could see. But we need to make sure that also with cardiac drugs, you can be a dog chasing your tail because you add one after another and another. You increase the side effects, you increase the cost to the system without necessarily increasing the benefit to the patient. That's the sort of thing that we can do something about here in New Hampshire with crafting our specific legislation. So that was RSA 126 AA:2 1G 1E. Sorry, I can pass this around so that you can see it, but this is just one of those. And also we were speaking to the benefits of having preventative care. Right now, we don't require an annual wellness visit for somebody to participate in this program. If the whole point is to get care early, shouldn't an annual wellness visit be one of the conditions for continued coverage? Now, I would argue that if we're trying to get ahead of medical catastrophe, it should be. So that is, sorry, I was going one side. I think this is what's going here. Yes, here we go. So this is just one area where we could make a difference and improve this and improve the quality of care, improve outcomes, and improve things.
Mr. Chairman,
Yes, Representative Nadarapam.
weren't we, it seems that Representative Leon is introducing an amendment, and I thought we were in voting mode.
Well, she didn't make any motion, so I'm thinking she.
Yeah, I believe she did make a motion.
Did you make, I'm sorry.
So yes, I had moved to retain, and part of my reason for retaining is all of the massive
No,
changes
no,
that we should
I
make.
understand, but I
Yes.
just thought if we're in voting mode, I would like to vote. And then if we're going to be in amendment mode, we can be in amendment mode. But I think
I believe we're in discussion mode after the motion.
I believe
you
you.
just introduced an amendment.
You can pass that back. That was for discussion purposes to highlight how we can make one specific change to the law that we have in New Hampshire where we're able to do some things, but not all. So that was as an example. I apologize. We can pass those back if you would like. I was just trying to be helpful.
That's how I had interpreted it, as it was just in support of her motion that she had distributed that, so. But we certainly don't want to muddy these waters anymore, so. Representative Merchant.
It's more of a comment than a discussion, but regardless which way we go with this, if we do end up passing this bill, I do recommend highly that we advocate to the speaker that Representative Leon be one of the representatives that's appointed to the commission. She has a lot of valuable insight and knowledge. I think it'd be very valuable for that commission.
Okay. Other discussion? No other discussion, okay. You know, I suspect we know how this motion might well go. 10-10 probably. And I suspect that's going to be true of almost any motion that's made on this bill today. We're going to continue 2 other bills. Is this worth continuing until next week?
No.
Representative Shapiro.
I think that we've, if we haven't had the last 5 years to think about this, we've certainly had the last few months to think about this and to hear testimony and to talk among our own caucus. I'm sure the Republicans have talked among their own caucus. I think that, I think we probably have very different opinions. But I don't think that we're going to we're going to improve things by taking more time. I think I guess I'm only speaking for myself, but I'm ready to vote on this. And if this doesn't pass, on various amendments that people have and to discuss them and vote on them.
Okay, anyone else want to comment on this? Representative Leon.
I can withdraw my motion. If it looks like this is going to be deadlocked, I thought that it would be pretty clear that we had more work to do, but I'm going to withdraw my motion.
Okay, so there is no motion on the floor.
Person made a second should withdraw too.
Yep.
Yes, Representative
I
Cushman did withdraw.
May we recognize for a motion?
Representative Cushman?
Yes.
Yes, go ahead.
Going to introduce an amendment. I move that we pass Amendment 1622 to SB 263, and I will pass that around for everyone.
Okay, was there a second to that motion? Second. Representative Leon seconds. Representative Cushman, do you want to speak to your motion?
Yes, thank you. So going back to that discussion and that paper that I passed out to everybody that you have about the evolution of this section of RSA 126 AA, where it speaks to the federal match rate, and if that goes below 90%, that's not in statute anywhere. So I would like to see that in the RSAs that govern this program. And so the amendment you have before you does just that. It puts in that if the you'll see on line 13, if the federal match rate applied to the program falls below 90%, RSA 126:AA shall be repealed 180 days after the rate change occurs, and that the commissioner, within 48 hours of the rate change, shall notify the governor, the Speaker of the House of Representatives, the President of the Senate, and the Chairperson of the Fiscal Committee of the General Court, Secretary of State, and the Director of Legislative Services of the program's pending termination, and within 10 business days of the rate change, notify program participants of the program's pending termination. So this just goes back to if we are touting this program as having these taxpayer protections, we better make sure that they actually are in place and that they are in the RSA and easily able to be found and are very clear in common language. And the beginning of the bill on line 5 is just talking about when that part would take effect.
Okay. Representative Seth King.
Thank you, Mr. Chair. Question for you, Representative, and that is it your understanding that if this provision were not in the bill and there were some sort of, deadlock in spending from Congress or whatever, and the federal government didn't pay their 90% share, that the state as it currently stands would pick up the 100% of the bill?
Yes, that's my understanding is that we would have to, because as of right now, the 10 and 90% is not anywhere in statute at all.
Okay, and then my other question would be for anybody else that could show me otherwise. If Representative Cushman is incorrect, I'd like to see proof of that. Thank you.
Representative Murphy, did you have your hand up? Oh, I'm sorry. Other discussion on this amendment? Representative Leon.
Thank you, Mr. Chairman. I'm looking to find the specific things, but was your request to OLS was to place this within the statutes into the RSAs. Is that correct? Correct. They left this in chapter law. So
I see that.
This would need to go into chapter law. I fully support moving the language from chapter law in 2018 into 126 AA, because I think that without that, we're legislators. We've been trying to track this down for a while with the help of OLS, and it's still been challenging.
Thank you. And that's, thank you for pointing that out, because I specifically asked for them to create a new section 7 after section 6 in that RSA. So I expected that it was going to be in the right place, but I didn't catch that. So thank you for catching that.
Mr. Chair,
I'm sorry, Mr. Representative Merchant.
just a point of order. I'm trying to go through the RSA that's being referenced here. Are we trying to change RSA 342:25?
May I respond?
Sure, go ahead.
Representative Merchant, so that's chapter law, and that's that is not what I was trying to do. I was trying to put it in RSA 126:AA. I'm sorry, 126-AA:3, and it would be a new section Roman 7.
Is this
read-
amendment ready for us to consider?
Well,
Well, now that we've pointed out that it's
It's in-
still not putting it in the RSA,
it's-
no, it is not. And I would
it's
need
in-
OLS to
Mr.
fix it.
Chair, according to what I'm seeing
Representative
here,
Merchant.
it says grading and marketing of, and sale of eggs, which is 342,
Right, they're referencing the chapter law,
not the RSA.
rewritten too.
Okay.
Representative Leon?
I think that was.
Okay. All right, so this is.
So,
Go ahead.
unfortunately, it looks like that this amendment is not ready for us to introduce. And this just furthers the point why I think that we need to retain this so that we can make sure that we have the amendments all back from OLS as we would like them to be. We need a little bit more time to go through these things. I think this is a really important piece of this legislation if it's going to go forward. So I would ask the committee if we can't do this now, we could attend to other amendments. But I would like to have a chance to go back to OLS and have them fix this.
Are you withdrawing your motion then?
Yeah, I'll withdraw my motion.
I'll withdraw my second.
Okay,
And then if I could be recognized for a motion after
sure.
that.
Representative Leon?
Thank you, Mr. Chairman. Since I'd already passed it out, it seems an appropriate time to move that we adopt Amendment 1494H to Senate Bill 263 FN.
Okay, is there a second? Representative Missouri seconds. You wish to speak to your motion?
Yes, thank you, Mr. Chairman. That,
Would you keep yours, Representative?
yes.
Here it comes.
Thank you. So there's already existing law within the different programs here. If I can get to this section in 126A, so I can tell you what this first one falls under. 126 AA. In section 2G, which 2G is the commissioner shall include in MCO contracts with the state clinically and actuarially sound incentives designed to improve care quality and utilization and to lower the total cost within the Medicaid managed care program. This commissioner shall also include in the MCO contract provisions an obligation for the MCO to include provider alignment assistance to leverage. And so initial areas to improve care quality and utilization and to lower the total cost of care may include but are not limited to. And that's where we get to the section A that currently says reduction of polypharmacy resulting in drug interaction harm. This is a very good opportunity for us to look at a subset of people and see what polypharmacy issues we have. This would be a chance to see who is on, statins and then other drugs that may or may not be working towards the same goal. We may be looking at people that have multiple different psychiatric drugs, and also looking at cross reactions across other ones. This is an issue that I've spoken with colleagues about, and polypharmacy is a clear and present issue. It increases the cost of care, it can decrease outcomes, and this would be responsible to include that in the contracts with the MCOs. The second one is another one based around improving outcomes. So in the RSA section 2.7, that chapter starts off. Actually, that is the whole paragraph there. For any person determined to be eligible and who is enrolled in the program, the MCO shall support an individual to arrange a wellness visit with his or her primary care. And then it has what the wellness visit includes. If the whole point of having this coverage available to people is to get earlier treatment, annual visits are a very, very good step towards that, because that's our chance to do screening. This is our chance to intervene before somebody is showing up in an emergency room. If we're looking to provide care earlier, then annual visits are important. And this also adds the language that the annual wellness visit shall check for polypharmacy, especially in the areas of cardiology and mental health, to avoid dangerous drug interactions and side effects. I recognize that providers have short time periods to visit with people, but if we're looking and trying to reduce harm and to improve the quality of care, I think that this is an important step, because that way the people who are using these benefits will use them, And we won't be paying the rate for people who are not interested to get an annual wellness visit. Yet we're still paying on an annual basis for their care that they do not receive. So this is a bit of a give and take. You go to the doctor, we still have this coverage. And I think that that's reasonable when we're trying to get into preventative care and to stop downstream harms.
Other discussion? Yes, Representative Polazov.
More like a comment. I want to thank Representative Lane for bringing this amendment, especially in terms of areas of cardiology. Science is evolving. As a nation, we are spending billions on drugs like statins, but still cardiology problems remain high, not solved, and often lead to death of patients. So it's important to study this polypharmacy and actual help or lack of it and side effects. So I'm very thankful for bringing this amendment.
Representative Palmer.
So thank you. I completely agree on the idea that polypharmacy is a huge problem, and certainly a number of people I admit to the hospital are in the hospital because of it. And the idea of an annual wellness exam, the only question I'd have there is whether this is a particular program, whether that would be covered under the program like it is under Medicare. But the idea is that's great. I think the reporting is where I begin to have a problem. It would be great if we're going to do a reporting thing to have it across everywhere, because if you have one particular group that's you're being asked to report on as a physician in your office, keeping track of that would be sort of an impossible nightmare. So that would be, so I'm not opposed to the idea. I just don't know how that would work, because if I see, 15 patients, 20 patients in a day, I don't necessarily know what insurance they have, and I don't know what, and this has been a real problem about trying to figure out which things to report on, which things are important, and then having all of the different payers agree and agencies agree on which things. And so I would prefer to see that approached that way, as the ACO in Vermont has struggled with this, but has come up with a thing where they've sort of tried to reduce it into one thing. So, if you're practicing in Vermont, you sort of know that you're going to be looking at these 12 things rather than 5 things from one insurance and 7 from another.
Other Representative Murphy.
Thank you. Just a question, clarification. On line 18, the word support, what is the intent of support? Is that arrange for a visit, pay for a visit? How do you define support there?
Thank you. That's in the existing language and is yet one more example of how the whole statute could use some good close attention. But I agree, it doesn't say whether it's paid for. It doesn't say if you just send you a postcard to encourage it.
Right.
It doesn't say if you do some skywriting and put an ad on the TV. So it's, and we've seen some different outreach. I could sew another eel and skydive in with a 70-foot banner behind me, but I'm a little out of practice. So I agree. That's a very vague term.
I hear the landing's going to be quite dangerous. Representative Merchant.
Thank you, Mr. Chair. I do concur also with Representative Palmer. Polypharmacy is definitely an issue, particularly some of the elderly that we run into. I would say that the appropriate place to add the reporting is not so much in the statute here, but also in the commission's responsibilities. And that's probably the logical place to add it if we want to add it. Number 2, as far as the annual wellness visit, totally agree with primary care, but under Medicare versus Medicaid, a wellness visit could be done by more than a primary care. It could also be done by a pharmacist, because we do medication therapy management constantly. People who are on polypharmacy are required to get a visit by pharmacists, if you will, to check on the polypharmacy. And I think it's also a place that we could add the role of the pharmacist in this capacity to help in that, to identify potential patients with potential polypharmacy as well. So for those reasons, I think number one is it should be in the commission responsibilities, not in the statute per se here. And I think number two, we should be thinking about adding other individuals that have access to the patient record to help identify polypharmacy as well.
Other discussion? Representative Leon.
Thank you, Mr. Chairman. I think with that, it probably would make sense for me to go back. I guess, is there support for me moving that to a commission responsibility to try and collect that information and then to include pharmacists? Looking at this, having the annual wellness visit checked for that. Quite honestly, if that became standard practice for everybody's wellness visit, it would be a net positive for everybody's health in the state. But if we had them getting that information and included pharmacists, are there any other care providers, or does primary care provider cover everybody but pharmacists that would do a wellness visit? Representative Merchant, is there anybody else I should include?
No, because most of the time when we talk about primary care, it includes the physician, PA, or nurse practitioner, maybe even naturopath, but it doesn't per se include the pharmacist. That's why in the Medicare regulations, it does include the pharmacist in that language.
Thank you very much. With that, I'll withdraw this amendment so that I can send it back for improvement. Would you withdraw your second?
Okay, so that amendment, we will wait to hear more about, I guess. You're planning to bring that forward next week.
Yes.
Representative Cushman?
Thank you, Mr. Chairman. I have another amendment here. This amendment is 1489H, and I move that we pass it.
Okay, is there a second? Representative Palazzo, seconds.
Hopefully we have enough.
You wish to speak to your motion?
Yes, thank you. So this amendment that's going around would add in section 2 of that RSA 126 AA under Roman 2 subsection A. It's going to add a fourth section to this. There are some requirements under that part of the statute. To the extent allowed by federal law, the individual shall. So they provide necessary information for financial eligibility. They inform the department of changes in their eligibility, and at the time of enrollment, they acknowledge that the program is subject to cancellation upon notice. And going back to what we were just discussing, the MCOs get a capitation rate for as many people are on the rolls. So we are paying for as many people are on the rolls, whether they utilize the care or not. And so it would make sense that we would periodically go through those roles and find out if there are anyone who is not utilizing the program. And if they're not utilizing it, well, then they probably don't need to be a part of it, and that don't need the benefits and should be taken off the rolls. And that would be a responsible way to operate. Section 4 says at the time of enrollment, they shall acknowledge that an underutilization of benefits shall result in the termination of benefits upon annual re-verification and re-enrollment. A minimum utilization of benefits for the purposes of this section shall be defined as one annual physical examination with a licensed primary care provider within 1 year from the date of enrollment or annual re-enrollment. I'll take any questions.
Representative Merchant.
Thank you, Mr. Chair. So, Representative Cushman, I hear the concern about underutilization and paying for benefits that are not being utilized. I do concern myself on the other side of the coin. Are we encouraging people to overutilize to prevent the underutilization? So therefore, we're trying to, in some ways, have an unintended consequence where overutilization may be triggered as an unintended consequence to try to figure out how to tackle underutilization.
Thank you for the question. Well, there's no definition of overutilization here. It's just underutilization, which is a very, very low bar. Just says that you have to see your primary care provider at least once a year. Beyond that, that's appropriate. That's an appropriate level of utilization. And if you go to your primary care provider and they find something and you need to utilize further services, that's what the program is for.
Representative Shapiro.
Thank you, Mr. Chairman. I will vote against this amendment. I think people's lives are very complicated. I think people who have limited resources, their lives tend to be more complicated. And in general, if people are not utilizing care, then there's no payment for services. I understand that there would be a payment for capitation for the managed care. I have no idea what that payment is, what the difference would be to the state for one person or 10 people who were taken off the rolls because of underutilization. But I think people's lives tend to be very complicated, and people, I know I don't go to the doctor when I don't have to, and I don't go to the doctor when I'm feeling well. And, then something of, great significance could come up, and I'm really appreciative of having care available. And I think that that's what we're providing for people, to have care available. So I will vote against this amendment.
Representative Murphy and then Representative King.
Thank you. I also would vote against the amendment in part principally because I think that legislating healthcare and the practice of healthcare is probably not our purview. There are many people on Medicaid that are in their 20s and 30s. They're in excellent health, and they've got jobs to keep, and they may not be able to go. They don't feel bad. They don't. If you were to query everybody around the table, I'd ask, how many times did you see your primary care when you were in your 20s and 30s? I would say that was not very often. But you want to have the health care available for them if they do need it. I'm also concerned with that provision would overburden the primary care provider, that they would be seeing a patient for an unnecessary, unneeded visit, and when other people need to come in and be seen. Lastly, I would say that primary care has a very broad definition, and it's not just your general practitioner. It also could be included your pediatrician. It includes your OBGYN. So I think that definition is just a bit too lax without any specific definition. So I would oppose this amendment.
Representative King.
Thank you, Mr. Chair. I just want to thank Representative Cushman for the intent, but I would like to parrot what my previous three representatives, colleagues, have said. I agree with them. Thank you.
Other discussion. Representative Cushman, did you?
Sure. Well, I just want to say that point that's being made is contrary to the spirit of this entire program, especially since that part of the MCOs, their goals is so that everyone gets primary care. And it's been stated numerous times by our lobbyists and members of the public who came to testify that primary care is an essential piece of this because it's going to reduce uncompensated care in hospitals later, which was another goal of the program. It's starkly in contrast to that. If that's the goal, then we should be making sure that people are actually attaining that. And actually, the MCOs incentivize patients to go and have their visits with their PCP. They actually give them a little benefit card that they can get money on, and they get money for going to their primary care doctor. So I think that's a stark contrast with the spirit of the program, but I'll leave that there.
Representative Leon.
Thank you, Mr. Chairman. I too am a little bit confused. It seems that there's sort of two thrusts to this program. There's the primary care provision, making sure that people get appropriate primary care to prevent significant negative outcomes later. And then there's this idea of catastrophic care. You're talking about the uncompensated care. You're talking about somebody who crashes their parachute into the ground and breaks a femur, that sort of thing, that they otherwise may not have had care, but they're having this. So primary care avoids all but those accidents. It helps to intervene earlier for all except those actual physical accidents so that we can reduce the overall cost of care. And it was my understanding that that is the main part of this, because looking to the whole system, if we're looking at the uncompensated care for accidents, other expensive end stage healthcare costs, I'm almost wondering if then it becomes less expensive for us as a state to have a fund to pay for this uncompensated care, especially because right now we're paying $50 million in state money with $450 million in federal match in order to cover about $100 million in uncompensated care. So if our thrust isn't actually primary care and getting that early care, then I'm starting to wonder, especially if we don't have a guarantee that the program would end if the federal government backs off on their contribution rate. Are we going to end up being in a better position financially being tied to this program versus just being ready as a body to say, here's our uncompensated care fund. Here are the people that have reached that catastrophic issue, and we'll cover that if we're not willing to incentivize primary care in order to intervene earlier. So I'm just having a hard time wrapping my head around these two competing interests and why there would be conflict with this amendment.
Representative Palmer, and then,
Well,
and then
so there-
Representative.
Oh,
Oh, okay.
I'll start and you can finish. Thank you. One issue I have with this is that where in the previous thing we were talking about supporting wellness visits, and it's great to start off that way, but I don't think any other insurance company requires you to go every year to maintain the insurance, or certainly my employer didn't require that of me. The other thing is that for most people under the age of 50 or so, well, even people over that, an annual visit is no longer part of the recommended scheme for anybody. So if you look at the, American College of Physicians recommendations, American College of Family Physicians, they have specific recommendations on screening over time, but it doesn't include an annual physical. And so to require that of this particular group doesn't make sense to me. Encouraging them to get that annual wellness check, yes, but requiring it as a condition of remaining insured is a different thing, particularly when it's not recommended medical care anymore.
Representative Nagel, did you?
You said all the smart stuff I was going to say, but I remember getting a beautiful chart of what the screening wellness recommendations were. And as you said, my age group, they don't recommend an annual physical at all. The only reason I get one is I'm on a med and he wants to see me once a year to tell me I'm fine. But the recommendations right now are not annual. Am I correct? Yeah.
Representative Shapiro, you all set? Okay. Anyone else? Any other discussion? Representative Leon.
Thank you. I have a question then. If these screenings and these visits aren't covered, are we paying for that in the MCO contracts to have these annual visits if they're against guidelines?
So that's that covered or not. I mean, I as I said before, encouraging people, particularly on enrolling in the program, especially if they haven't had health care, encouraging them and paying for an initial visit to establish whether they have any problems makes a great deal of sense, because that's where you can then prevent, you find that this person is diabetic. Great. Now you've probably saved a ton of grief and money. But sort of arbitrarily having it every year just to stay in the program isn't going to contribute to health. It's just sort of it becomes just a hoop to jump through, which would end up with its own set of issues.
Representative Cushman.
I just have a question for Representative Palmer. I know you're calling it a hoop to jump through, but this is taxpayer funded. This is a entitlement program that's funded by tax dollars. I think that there should be some baseline accountability. And would you agree that we should have some checks on this?
So, thank you for the question. The simple answer is, I guess I haven't thought about this enough to really give a thorough answer. Probably if you'd said, if this were, people will be required to have an initial visit within a period of time for wellness, then you've sort of accomplished what I said, which is you see whether this person has sort of hidden high blood pressure, diabetes, all of those things that we should screen for, but you're not then requiring them to come back every year if they were completely healthy and are 32 years old. And you're also not going to take away the insurance that they may need if they have an injury, just because.
Okay, so sorry.
Go ahead.
So like a different iteration of this idea though, you might support like if it was within the first year, they need at least one visit with a primary care physician.
Yeah, and the only other caveat, getting back to what Representative Murphy said, is these people may have a hard time getting that visit, and so you'd have to allow some kind of leeway where like they've tried 9 times and they finally have an appointment for September of next year, but at least they're making the effort.
Okay, thank you.
Representative Merchant.
Following up on Representative Palmer's, I do agree that probably when they first come into the program, sometimes when they first come into the program, they may not have had health care for a period of time. I check in at that point to sort of help guide the primary care person to look at a screening. If there's nothing found, then I would say at that point, it's probably up to the patient to develop symptoms of something to go back to the primary care doc. However, on the other hand, if they do find diabetes or something of that nature, they probably should be going to the primary care doc at least once a year. So it's more of a step process where the first time, if you haven't been to a primary care doc because you didn't have any insurance, you got a Medicare expansion, you now have the coverage, therefore you go see the primary care doc. I think at that initial visit is for them to take the time to screen the patient to find out there's something that needs to be followed on a routine basis.
Representative Nagel.
This is going to be an incredibly cynical statement, but I mean, going back, it's the whole basis of patient-centered care. Every patient's unique, every patient's different. We do have routine protocols for everybody, but they're not annual. You have that initial visit, you make your decisions for that individual patient, and frankly, that's the way we did things 30 years ago before everybody started telling us what to do, and it worked just fine. And I mean, that's the way the system should work.
Representative Murphy.
Thank you. Yeah, and I would just reiterate that I would not be opposed. I don't like the idea of legislating medical care, but on the other hand, to enter into this program with the recommendation or a requirement of having a visit within the first 12 to 16 months so that they get in there. It's not just checking their blood pressure and seeing if they have high blood sugar. They would also do an exam, a family history exam. So if you have a history of colon cancer, you may recommend that they get their colonoscopy sooner. Or you have a history of prostate cancer, you get it done sooner, your PS, whatever it is, breast cancer, whatever. So you take, it's not just the blood work, it's not the blood pressure, it's also the family history. But I fully support wellness exams. And I think that though I'm hesitant any time to require a visit because I don't want to clutter up offices, I don't think it would be inappropriate to strongly recommend in some language that they see somebody initially for their care and evaluation.
Representative Shapiro.
I think I understand philosophically what this amendment is trying to get at, which is that patients should have some skin in the game and there should be accountability. It's a public program that uses taxpayer dollars, and therefore there should be some accountability on the part of patients or recipients. So I understand philosophically, I think, where this comes from. But I don't understand, what I don't get is there a specific problem that's borne out by data that says this is something we have to fix? I mean, do we know that people are underutilizing care or not signing up with a primary care service? So is there data that points to a specific problem that we're trying to fix with this amendment? Because otherwise, it feels to me like it's just punitive, that it's just, and really, I am concerned about the dignity of the patients also, that we not be micromanaging what they do and what they don't do, unless there's a specific problem that we're trying to remedy.
Thank you for the question. Respectfully, the specific problem is wasteful spending. I mean, that affects the entire state. If we have people on the rolls for this program that never utilize it and really don't care to utilize it, why do we pay the MCOs, per person who's on the rolls? It's not a responsible way to do business. And in New Hampshire, we tend to be responsible with taxpayer money and with entitlement programs. So I think putting a little, you hit the nail on the head that this is from a matter of, it's a matter of principle in governing. If we are to offer programs, there needs to be a little bit of accountability. And I think that this entire program, because it's mostly the way that the federal government has designed it, and our community engagement aspect of it is not enforceable, there is little accountability in it. So I would just like to see that we're making sure that it's being utilized, and if it's not being utilized by some members who are on the rolls, that they should be removed, and they should just agree to that when they apply for it.
Follow up.
Follow up, Representative Shapiro.
I'll address this to you, but Representative Cushman, but anybody might know. Do we have any data on how many people do not go to their primary care provider, or what percentage of people do not utilize the program in a way that we may think is the right way to utilize it?
It's a good question. I don't know that we do, but we probably should.
Representative Palmer.
So I mean, this is getting into the weeds, and maybe somebody from HHS can answer this, but I mean, we have a managed care organization running these programs, and I think that the rationale is probably that the numbers in New Hampshire are too small to make it, what's the word that insurance companies use? The bottom line is that if we have an MCO, that it's going to cost the state a fixed amount per number of patients, and we don't have to worry that 7 of them end up needing bone marrow transplants and that the program gets blown out of the water. And so on the one hand, you're concerned about having people who are paying so much per month to be in the program is a problem, but we're doing it that way because overall we think, or whoever set this program up thinks, that that's going to A, save money in the long term, but B, prevent big financial spikes that would be a real problem. And I don't know if there was a choice, whether New Hampshire chose to go the MCO route, and California, they're big enough to self-insure, so they're doing it on on a regular basis.
Representative Nagel.
Thank you. This has been a very interesting discussion. Thanks for bringing it up. I would probably be willing to answer your question earlier, Representative Cushman. I think I would be willing to support a statement that, say, within a certain time frame of either before or after becoming enrolled, that you were expected to see your doctor, and then the doctor and you create a strategy for long-term management of problems you do or you don't have. A lot of these patients already have a relationship with the primary, so I would include, prior experience in that, whatever definition you chose to make. But I think given the circumstances as you've raised them, I think that makes sense.
Representative Leon.
Thank you, Mr. Chairman, and thank you, colleagues, for this great discussion. It seems like this whole idea of an annual visit may not be appropriate, but I'm curious about whether having a care plan that's agreed upon by that primary care provider and the patient would make sense. That way, if you had a condition that required more frequent monitoring, there would be that incentive to actually come and show up for your appointments. But if you were healthy as a horse and they said, we'll see you in another 5 years if you're still on this program, or even if not, I'll see you in 5 years, unless you have a problem, that if there was an agreed upon care plan, that may be something that we could help keep people to. Because I know there's a lot of people that don't necessarily like going to the doctor. And I know there's a lot of people whose schedules fill up with everything that is not the necessary and required. And it's really easy to put your health on the back burner, especially if you're a parent with small kids. But if you do that for too long, there might be a fire on that stove. And if we can figure out, if we can have a care plan that's agreed upon by the primary care and the patient about how frequently they would come in, that could be negotiated and be considered something that would be reasonable. Obviously, it could be fleshed out in rules, but that might be some way to sort of get some better buy-in between both the patient and the physician about how frequently they should come in. And if we're paying a capitated rate for people to come in and get care, I think that that would show a longer-term reduction in the cost of care when you know that you have people who are actually showing up to their appointments. Because I do know from the device world and looking with the hospitals at that time, people who don't follow up on their treatments can often end up with often end up, I would call it unexpected, but unfortunately, when you look at the actuarial tables, it's an expected outcome, just not for everybody. So I'm curious what people would think about a care plan for visits as opposed to an annual recommendation, because that could allow those who are both more medically complex and those who are a lot less medically complex, both to get a better idea of the playing field and figure out how to collaborate going forward.
Representative Merchant.
I want to say thank you, Representative Leon, for what you're bringing forth, and also Representative Cushman for the discussion. We don't place any of these requirements on the employer-sponsored healthcare. It's a free market. They basically, at that point in time, negotiate a plan with the insurance companies based upon what they decide that they want to cover and what they do. So I don't know why we're getting into the micromanaging of trying to figure out what to do with Granite State Advantage with the MCO contract. I think I'll go back to what I said before. A lot of this belongs in the commission, not here in this legislative body, and let them bring the recommendations back to us as policymakers to make a change in the policy if we need to. But again, I go back, when we have commercial insurance companies out there, we don't try to micromanage them either. So why are we trying to do it here today?
Representative Cushman.
Thank you, Mr. Chairman. I reject the comparison between a employer who's paying for health care for his employees, and that's their choice, to taxpayers, a taxpayer-funded health care plan. Taxpayers don't have a choice. They pay their taxes. It comes out of their paycheck from the federal government, and from their business tax, enterprise tax, or what have you in the state. But it's completely different. We have a vested interest in ensuring that this program is responsibly run, that there are checks and balances for financial responsibility and enrollee accountability. It's completely different from an employer-sponsored private insurance.
Other discussion? Representative Leon.
Thank you, Mr. Chairman, and respectfully, I'd like to weigh in on that as well. As the legislators, we are the ones entrusted with figuring out where to put the state's dollars. Employers who are buying employer-sponsored health insurance have the opportunity to make changes and make choices within their insurance. As the market standardizes with more and more people on standardized care, like Medicaid, Medicaid expansion, and some of the other programs that simply follow along, there's less and less choice for those employer-sponsored plans as well. But as the stewards of taxpayer money, it is our job, respectfully, to put out some of those requirements for those MCO contracts. And that's specifically why this program needs to be reauthorized from time to time, as opposed to approved in perpetuity.
Other discussion? All right, if there's no other discussion, I'll ask that the clerk call the roll. Motion is out to pass on Amendment 1489H to SB 263.
Representative Leon,
Yes.
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Boyd. Yes. Representative Seth King,
No.
Representative Mazur,
Yes.
Representative Nagel. Representative Polozov,
Yes.
Representative Cannon.
No.
Representative Wallner,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant,
No.
Representative Murphy,
No.
Representative Palmer,
No.
Representative Lloyd,
No.
and Representative McDonald.
Yes.
8 to 12 fails.
Motion fails 8 to 12. Okay. I don't know how long the next discussion is going to take. One of you has indicated, at least one of you has indicated they need to leave at 3. So I'm here for however long, but obviously it's an executive session, so. Representative Leon?
Thank you. I think that this one will be a little shorter, so I don't know if I could introduce this amendment.
Sure, I'll
Uh,
give it a whirl.
I move that we adopt Amendment 1629H. I will pass that around, and this one is about the acceptability of waivers. Sorry, let me count these. I know there's some in this stack somewhere. Let's send these along this way. Sorry, I should have put the box on the table. I was trying not to scare anybody with my file folders, but it would have been a lot cleaner that way. I may have sent too many along on that side.
This is what she was looking for.
Oh, here we go.
1629.
There's some more.
You want
Yes.
this one?
Sure.
By any chance?
Thank you. Okay, I can pass these along that way. I found the rest of the stack. I apologize.
This didn't get printed on both sides.
Oh. Okay.
That's a
So,
single-sided
so,
one.
so there's 2 pages.
Yeah.
The 1629H, the amended analysis, and then the main amendment.
Is it on the back?
No.
So that here's.
There was one that came out not double-sided because the pages stuck together. And I don't think I successfully removed that from the stack, so I apologize. If you got just the amended analysis, you can probably trash that. The main part of the bill is the section inserting section 8 into the statute in 126 AA. Sorry, yes, inserting this. So what it's just doing is amending part of the underlying bill that we are looking to potentially reaffirm in perpetuity. In the statute right now, it gives rulemaking authority to the commissioner. But I'd like to know who in this committee knows how to define the terms unreasonably inconsistent. Because that is the.
Representative Leon, was
Oh,
your
sorry.
motion seconded? I'm sorry.
Was there a second?
Representative Palazzo, seconds.
Got it.
Sorry, thank you. Thank you. Want to thank the clerk for pointing that out to me.
Yes, thank you.
Go ahead, Representative Leon. Sorry to interrupt.
Definitely. I think we all need some more coffee soon. So I was also digging through all the rules associated with this program. There's more issues there within the rules and them going outside of the legislative prescription. But right now it says that the rules should be consistent with the terms and conditions of any waiver issued by the Centers for Medicare and Medicaid Services for the program, provided that any waiver issued is not unreasonably inconsistent with the provisions of this chapter. And then it gives some conditions. Unreasonably inconsistent is something that I can't quite define. I'm not sure if anybody else can, but I think that just gives too much authority that any waiver that comes through amended would then go into our rules and then have the force of law. So in order to address that and address the fact that if this is adopted permanently, we would be putting into our rules whatever waivers come down from the federal government and giving the force of our law to those waivers. It should not be in conflict with any of this enabling legislation. So that's why I have this amendment here in order to make sure that any waivers that we accept by putting them into our rules are not in conflict with our enabling law.
Discussion. Wow. Guess it is going to be shorter. Okay, if there's no discussion, I'll ask the clerk to call the roll. Motion is ought to pass on Amendment 1629H.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofal,
Yes.
Representative Boyd,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Cannon,
No.
Representative Wallner,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant,
No.
Representative Murphy,
No.
Representative Palmer,
No.
Representative Lloyd,
No.
and Representative McDonald.
Yes.
10 to 10, motion fails.
Looks like you have more amendments. Are they as short as this, or it's hard to tell?
I mean, honestly, yes, there's another short one here. I guess I honestly thought there'd be some discussion if there was dissent to that amendment. If you want to offer another one?
So it's, I move ought to pass on Amendment 2023-1620H to Senate Bill 263.
Is there a second? Representative Leon seconds.
Thank you. So this amendment,
If
which
you
I'm
distribute it.
passing around, is very simple. So as we were talking about the community engagement requirement, that's the work requirement. Currently, it's not enforced, and I was told that there is a chance that the federal government may be changing their approval of these work requirements, and Georgia now has one in place. So ours got kind of kicked around the courts, and then our request for approval was withdrawn. So we could request approval of this again, and I think that it is our duty to do so, to apply for the Center for Medicare and Medicaid Services to approve our community engagement requirements under this section. So this just directs the commissioner within 6 months of the enactment of SB 263 to submit that request to the federal government.
Okay, thank you. Discussion. Representative Leon.
Thank you, Mr. Chairman. I think that this is absolutely critical. Our current statute, 126 AA, has plenty of requests for waivers, and it's important to put that request in so that it is the will of the legislature. And so I support this amendment.
Another discussion. Representative Shapiro.
I'm going to vote against this amendment. It is true that this was ruled invalid by a federal court. And what the federal court said was that providing Medicare to the needy is Medicaid's core objective. And the waiver failed to adequately consider the work requirements' effect on Medicaid coverage. In other words, that the core principle of Medicaid is to provide medical coverage, not to provide work readiness or character building. So that was the spirit of the court decision, which I agree with. So whether things have changed enough so that a waiver such as this would be reconsidered by the federal government? I don't know, but in any case, I'm against having this kind of work requirement, so I'm going to vote no on this.
Other discussion? Representative Cushman.
Thank you, Mr. Chairman. I got the history of this from Mr. Robert Berry from the department. And he did mention to me that the U.S. House of Representatives is considering legislation that would implement some form of community engagement requirements for CMS, and that it very well may be possible that ours would be approved. So I think now, while we have this bill in front of us, and while the federal government, is in their negotiations, there's nothing to lose by having this request submitted. We just need to seek this waiver if it's going to be available. And, it's in our statute already. So, the legislature has spoken that this work requirement should be in place. We want there to be a work requirement if this program is to be in New Hampshire. This is what makes this, part of what makes this a New Hampshire specific program. Otherwise, we're just doing whatever the federal government prescribes. So I think if there's an opportunity for us to implement it, that it's, our responsibility to try to.
Other discussion? Representative Leon.
Thank you, Mr. Chairman. I think this once again illustrates how a large section of the statute in 126 AA is not in effect because it's about the work requirements and the community engagement that is not enforceable. So once again, this is why we need to have a sunset on this and why we need to come back to this.
Thank you.
Other discussion? There's no other discussion. I'll ask I'm sorry. Representative Palmer, did you? I'm sorry.
You just turned it off. You just turned it off.
Turned it up. Sorry, thank you. I was just reading, and my concern would be this. So Georgia has just managed to get this passed through the court down there. But the judge there ruled it was substantially different from the case in Kentucky, Arkansas, and New Hampshire. So and the reason, I guess, is because Georgia had just enacted their Medicaid expansion. We already have it. So we along with Kentucky and Arkansas, it's considered a reduction in benefits by doing this. And so the court said that's a problem. But what Georgia did was they did it initially, so they were expanding their services. So I'm not a lawyer, but my concern would be if we try to push this and New Hampshire has to go to court, how much is that going to cost? And are we going to just run up against a brick wall again?
Representative Cushman?
Thank you. Well, it doesn't say that we have to carry it to, push it through the courts. It just says that they have to submit a request for approval of the waiver. I mean, of the community engagement. So, and as by that time, within 6 months from now, legislation may have gone through on the federal level that permits that to be operable.
Other discussion? Representative Palazzo.
I will support this amendment. I think it reinforces the intent of the underlying existing legislation, and it's very important to stay with that intent, because even though we had many testimonies that many participants of this Medicaid expansion are working and being engaged, we don't know what economic situation would be in 1 year or in 2 years, and what new participants of this Medicaid expansion will be, and in what circumstances. So I think it's important to ask for this approval. So I will support this amendment.
Thank you. Representative Nagel.
I'm going to admit my total naivety, but two questions. One is, where do I find the community engagement requirement? And secondly, we're just submitting a request to CMS who could easily just say no. Am I correct about that? And number one, where do I find what the requirement actually is? Most of my Medicaid expansion patients actually have a job, so I assume that would qualify them under.
Representative Leon.
Thank you, Mr. Chairman. The work requirements are in 126 AA. It is for 100 hours a month based off of a 25-hour work week. Within the language, it includes work in the private sector. It includes a number of different things, and so it's very broad-reaching. Even volunteering with a nonprofit satisfies that. Watching your children or babysitting others satisfies that work requirement. It is very broad, and it provides ample opportunity. There are also a lot, yes. Yes, it is. And also our committee researcher has said that she could provide some more information on work requirements for us as well for next week, if that would be helpful. I can find where the language is on these.
It's 126-AA:2.
And then also, as far as that goes, there's supposed to be an opportunity to cure if you're short on the hours. And this also is another area that needs to be addressed legislatively. The administrative rules with no grounding in statute said that nobody can be asked to work more than 100 hours, even if they're making up for a loss in the previous month. So as long as eventually you put in a month with 100 hours, you're considered in compliance. And given that if you have basically a doctor's note saying that you have a reason why you aren't able to participate, that there's if there's a storm that keeps you from attending, that you get waived hour for hour. There's a lot of trade-offs as well. And, you know, honestly, as a mom, I'm a little offended that the entire pregnancy period is considered a disability. I think that being able to continue on with life and work during your pregnancy makes sense. And the doctor's note during your pregnancy or any other time saying that you're not able to work, I think should be sufficient for anybody except that last week when you're saying, oh my goodness, it's time. Sorry, I'm getting into another one that I have here. I apologize for diverting my attention, but we have a very, very generous program that allows for a lot of different things, including on-the-job training, education, and participation in substance use disorder treatment, recovery activities, and/or mental health treatment.
Representative Shapiro.
I would agree with Representative Leon that there's generous opportunities to be accepted if you have a problem fulfilling the work requirement. I wouldn't say it's very generous, on the other hand, because it was the most hours required of any waiver given throughout the country. So the requirements were the most extreme in the country when we did get that waiver. Also, I think that in regards to the discussion about maybe there being changes in federal legislation that would allow these kinds of waivers, that has been discussed in the news recently and was included in the federal House legislation that passed recently regarding the debt limit. But I don't think that anybody really expects that will become it's got a lot of steps to go before it comes law, and it doesn't seem like that's going to happen, at least in the way it was passed in the House of Representatives. So it is being discussed on the national level, but it's far from being a reality.
Other discussion? Seeing no other discussion? So I'll ask the clerk to call the roll. The motion is ought to pass on 1620H, amendment to Senate Bill 263.
Representative Leon,
Yes.
Representative Cushman,
Yes.
Representative Bill King, yes. Representative Kofalt,
Yes.
Representative Boyd,
Yes.
Representative Seth King,
Yes.
Representative Mazur,
Yes.
Representative Nagel, Representative Pelosi,
Yes.
Representative Cannon,
No.
Representative Wallner,
No.
Representative McKay,
No.
Representative Freitas,
No.
Representative Nutter Upham,
No.
Representative Shapiro,
No.
Representative Merchant,
No.
Representative Murphy,
No.
Representative Palmer,
No.
Representative Lloyd,
No.
Representative McDonald.
Yes.
9 to 11 fails.
And the amendment fails 9 to 11. Okay, at this point, we might be pushing our luck with those of you who need to leave shortly. I do have a couple of announcements. One, I'll be sending out a list of the retained bills that just a number of us are wondering about them. And we also need to consider how we're going to handle those, not immediately, but obviously those need to be on our radar screens. And if we can start thinking about what areas we might be interested in working on those as time passes. Also, next week, the subcommittee on 240 is going to be meeting at 10 a.m., right? Representative Merchant, Representative Leon, and Representative Weber are part of that. They're going to be meeting at 10 a.m. So we're going to be this committee will be meeting at 11 a.m., right? And that is all I have. Yes, it'll be on next Wednesday, the 10th, yes.
Mr. Chairman, did we want to discuss about 238? About the floor amendment there?
Well, that wasn't really a noticed item for us, so I don't want to be accused of doing a work session again. But what I can do tomorrow is make an announcement. We'll have a brief executive session on the floor. I can announce that, and then I guess that'll be proper notice, because we'll all be there anyway, so. we'll
Mr.
handle
Chair?
that. Yes, Representative Merchant.
I believe that is going to be heard on the floor on May 11th. Is that the case?
238?
Yes.
Yeah, I've, yes.
Could we make the discussion of 238 for amendment during the work session next week? Then notice it.
If we discuss it next week, I don't know, would that be enough time to put it to discuss it on the 11th, the next day?
Be a floor amendment.
Representative Leon.
Thank you. My only one concern with that would be making sure that we could get it in time, if everybody was favorable of the change in language. I don't expect that it will, I think we'll get an idea of whether or not it takes us more time and would then need to be announced and put in for a work session on next Wednesday if we don't have an easy agreement when we meet for 5 minutes or so, I guess at lunch tomorrow at session. That was my thinking.
If I heard it correctly, thank you, Representative Leon. We have to notice the fact that we're going to have a discussion about it, which is a work session. So I guess the question to the chair is, do we have to notice it so we can have the discussion on it next week?
Yeah, a work session has to be noticed in the calendar. Yeah, Ms. Dyer, can you notice that for us? A work session on that amendment, SB 238?
Yes, and it will likely be a different amendment number, but a work session on Senate Bill 238. If we're able to notice that, since we have already reported.
It would really be an amendment, like, it's going to end up being a floor amendment or something?
Yes. Yes.
But something we're going to, I mean, is that feasible? Okay. Okay, great, thank you. All right, anything else come before the committee before we adjourn? Seeing nothing, thank you very much, and I'll see you next week. Actually, I'll see you tomorrow.